So we're starting trauma today. Where's my share screen? It's a great question. Come to me, share screen. So trauma is a little bit kind of more on the BLS side, but for some reason everyone kind of screws it up when they take the test because they forget, BLS before ALS. And just thinking logically, okay? The priority in trauma, no matter what truck you're riding, is that you need to get to the hospital. And here's your trauma llama to brighten your day. So, most trauma-related deaths can be prevented. Most of them are due to the fact that you could just avoid the trauma in the first place. Things like wearing your seatbelt or putting drugs like either medications or like drain cleaners and stuff in a spot that children can't reach, like that's all trauma. Poisoning is starting to kind of take over in terms of deaths because of the opioid crisis. Before that, it was all about dying in a, fiery car of doom. You'd be surprised the number of cars that just like randomly set themselves on fire. The stop, drop, and roll was really just intended for, apparently these days, cars bursting into flames. And this goes back a little bit to the very beginning of the class where we talked about planning, planning a response, right? So if you see that there's an issue, for example, maybe there's a curve that people take too fast, maybe putting in speed bumps or those little rumble strips on the road to kind of make sure that people slow down. There's different public health ways that these that traumas can be avoided. However, a lot of them are, ineffective after a while because people stop caring. Come on. So we talk about the different phases of trauma care. The first one being the pre-event, right? So what was going on before the injury occurred? So if anyone has worked in the city, or really anywhere, any intoxication is probably one of the number one ways that traumas happen, right? Who's driving drunk? Who's doing something stupid while drunk on a jet ski or with fireworks, or just the ability to kind of self-preservation skills seem to go out the windows the second that alcohol is involved. Heart disease is an issue, right? I want to say here in Garden City we have a record for a number of people who've had a heart attack and then crashed into an inanimate object while driving within a calendar year, because that's not something you see a lot. We've had 3. Poor vision, right? We talked about this a little bit, right? Blind curves and other factors in the environment that could exist, fog or heavy rain, snow, etc., can cause the perfect storm essentially for a trauma. And now we also talked a little bit about this already, where public education can help prevent a lot of issues, like wearing your seatbelt, or how about this right here? How about wearing a helmet while you're riding a bicycle? That was a bicycle helmet. This is right there is a grand example of what your skull could look like if you weren't wearing a helmet. And then you have the post-event phase, right? Which is the injury has happened and then we show up, right? We're like, hey, what's going on today? It appears that you've been waffled by a car. So now we're delivering, that emergency care. We're finding out what happened. We're trying to save a life, and we're trying to promptly transport that patient to the appropriate hospital. Now, appropriate hospital, because when you take a trauma patient to a regular old hospital, they can't help them. For example, if you're working in the Queens and you happen to be in the Rockaways, you're not going to take a gunshot victim, a patient, a headstroke, jumper down to St. John's Episcopal, because they're going to go, we can't do this. Go put him in the corner. You've just killed them. Frankly, I wouldn't necessarily bring any patient to that hospital, but sometimes you have no choice. Now, let's look at this picture real quick. And for those of you who recognize the abbreviation on the back of the shirt this gentleman is wearing. You're welcome. What's wrong here? And yes, I'm picking on the Jelly Volleys a little bit. Yeah, the girl standing there looking a little lost. Yes, that's good. Perfect. He absolutely is doing the right thing. He's looking directly down at the patient. The patient is wearing his glasses still, so he can, in fact, see the person who he's talking to. He's not strapped in yet, but what's in the EMT? I don't know. He doesn't think he's an EMT. What's in his hand? The headboard. Do we strap a head down first? Oh, BLS skills. No, that is the last thing you strap down in the event that you're using it. And this is an older picture. This is the last thing that you strap down during securement to a longboard. Okay? Don't do it. The stretcher's way too high. Let's talk about from a personal provider. Like, do you want to have to lift him that high? No. Don't do it. Like, nice and low. And we're going to talk about the dad footwear going on right here. This gentleman's wearing sneakers. I don't know if anyone follows the Spot the Volley Chief Twitter page. This gentleman's wearing loafers. Not appropriate footwear. Right, so there's a number of issues here that I have. This also looks like they've been there a while. If you have had enough time where the lifetime members of the fire department or the EMS squad have had time to show up, you have already been on scene too long for a trauma. That's just personal opinion. So there's things that we can always do better, right, during a trauma. And I understand there's a lot of adrenaline and people kind of feel like they're getting rushed, but we can do better. And that's kind of recognizing the issues and then bringing it to the next call so that you can improve. Why are we not moving forward here? Thank you. Yeah. Oh, if the detective showed up, then you're definitely on scene too long. 100,000,000%. Jesus. Hold on, I'm trying to move back. That's a detective? I can't go back. And I'm trying to... That's a detective? Alright. So, 100,000,000% have been on scene. On scene. This guy right here with the balding in the back. You don't see the back of his head? Alright. If the detective has already shown up, you have been on scene way too long. And that's definitely why that cop is doing more work than he should. He's like, oh, the detective's here. The guy's actually old enough to be my dad. Let me do something here. Actually, Suffolk cops are really helpful. I will say that much. So yeah, what's the rule? What's the general rule for a trauma? How long should you be on scene? 10, right? The 10, I think it's platinum 10. I think we keep changing it. It keeps getting upgraded to a different precious metal. 10 minutes, right? Because you have the golden hour and the platinum 10. So if you're there long enough that you've got detectives and cops and all of these other people showing up already, you've already been on there way too long. All right. Most important factor when it comes to making sure that your trauma patient is going to survive is time, right? Can we perform surgery? Can we do a blood infusion? No, we can't do any of these things. These people need a hospital. You know, when it comes to a medical emergency, we can act essentially as the emergency room, but not really as much when it's a trauma patient, right? We are not going to be cracking a chest and doing, a cardiac massage. That's not us. We're not that cool. If you want to go work in the UK, maybe. But these are not things that happen here in our system. So we need to make sure that we boogie. There's no reason that we should be futzing around on scene. There's no reason that you should be doing 6 different tries to get an IV. Your priority is to go to the hospital. You're going to stabilize wounds and go to the hospital. Stop bleeding and go to the hospital. Secure an airway and go to the hospital. Don't get fancy. and this is like where this thing of the ALS providers kill trauma patients, because we futz around on scene. I want to get the IV. Oh, I got to get the airway. Does a BLS procedure work? Then do it and go. Okay? Keep that in mind, because I've seen way too many medics, like, they got this guy who's bleeding out the eyeballs and he's a mess, and, oh, we got to get an IV. No, you don't have to get an IV. Go to the hospital. If you want an IV so badly, do it while you're moving. But you need to also make sure that you understand what a life-threatening injury looks like. You can't just be like, nah, it's fine. No, sometimes it's not. It doesn't hurt to up triage if you are genuinely concerned about the patient having life-threatening issues. Older patients who have suffered trauma, up triage. They have really terrible outcomes as it is. So, things that will kill you immediately versus things that will kill you a little bit later, right? So any sort of significant laceration or bleeding into the brainstem, or the upper part of the spinal cord, any significant trauma or damage to the heart, aorta, or other large vessels, right? You're going to get there and they're probably going to be dead already, right? They've bled out because their heart's no longer attached to the aorta. You are doing compressions, right? Traumatic arrests, very, very low survival rate. It's actually, when you guys do PHTLS, traumatic arrests are not even considered worthy of working up. We do that anyway here in the city, because that 0.01% possibility that they will survive means that we transport. Then you have patients who maybe look okay when you first get there, and then are less okay a few hours later, right? So maybe they have a significant head injury and you need to tube them. Maybe they have a liver or spleen injury, right? Because those two things bleed a lot. Maybe it's a traumatic pelvic injury, or femur fracture, right? Anything where the patient could potentially bleed out, but not as quickly as like just the heart at the aorta being severed there. And then you have patients who are going to die like weeks later. So, hold on. I actually was talking to one of the medics at Jamaica last night, and he's saying that they had a patient who, it wasn't a trauma patient, it was a hypothermia patient. The guy's core temperature was in like the low 80s. He was found, how do we say this? Soaking wet and snoozing on the sidewalk. So he was cold, very ice cold to the touch, and he actually ended up dying about almost a week later from multi-organ system failure and bacteremia. And I was like, well, where do you think the bacteremia came from? He's like, I don't know. Remember when we did GIGU? And we talked about how you are like 1 trillion, made of 1 trillion bacteria? This hypothermia, one of the significant issues kind of associated with hypothermia is that your gut, because the blood is shunting from the gut, it starts to get leaky. And all those little bacteria are like, ooh, let's go. And they start taking off. Like, we're out of here, guys. We're going to go explore some other regions. And then you die. So it's one of those things where you really need to look at the bigger picture. Because sometimes you can do as much as you know, as much as possible. You've stabilized, you've stopped the bleeding or whatever, but they're just not going to be doing well because of, sepsis. Other issues in regards to sepsis is if you have a patient who's been shot or stabbed or has bad road rash, they are also prone to, developing various infections. And now you're, as a trauma patient, you have a diminished immune system. So it's just a mess all around. So, trauma. That's tiny. Yeah, we're not gonna go in that. It's just really too tiny to see, but it's a nice algorithm, like, oh, should you go to a trauma center, right? So if you have a patient who's got a GCS of like greater than 14, and their blood pressure is 90, over 90, and the respiratory rate's good, okay, cool. Then you really don't necessarily need to go to a trauma center. Maybe you can be stabilized somewhere else. But as things start to kind of go downhill in terms of like the Glasgow Coma Scale or their blood pressure, their respiratory rate goes up or down one way or the other. They have any sort of significant proximal injury, right? So broken humeruses, broken femurs, gunshot wounds to the femurs or humeruses, or the core. You're leaning more towards go to a trauma center. Okay. And each hospital and slash region has kind of slightly different guidelines as to what goes to a trauma center or not. But they always leave, if you see here on the bottom in step 4, EMS provider judgment. So there's always a possibility that you should be going to a trauma center. So you remember your judgment. We talk about how EMS can be powerful. Your judgment can potentially get somebody the help, even though if you're like, they don't necessarily fit the criteria exactly. There are very few times in the New York City region that you will need an air transport. There's very few times in the Long Island region that you should be calling for a medevac. Kind of some of the examples of a really good reason is that your ground transport time is significantly extended. So, for example, if you are on Montauk Point and you need a patient needs to a trauma center, and you need to bring them to, I don't know, Stony Brook, that's like a 2-hour drive, they might need a medevac. No offense, Jolly Volleys, but y'all call for medevacs for things that don't need medevacs. Like everyone just like, I gotta call for the chopper. No, you don't need the chopper. Go ahead. Well, what's your ground transport time? Like, how long is it going to take for you to get a medevac? Because now, think of the time that you're spending, because now you have to go from wherever the injury occurred to a landing zone, do the handoff, and then they have to go to the hospital. So it's 10 minutes by ground or 10 minutes by air. Just take them. Because I think that's really the biggest problem right now in like the New York City, Long Island region is that there's no real time saved by going by air. It's minimal unless you're literally out on like Orient Point, Montauk Point, or you're in the Rockaways during rush hour. You're not really making up any time. Stony Brook. They make it look better. Yeah. Yeah, that's one of those, like, just go to Stony Brook. You're not, because again, now you have to, and now if the chopper's not up, you need to wait for the chopper to warm up, because it's not like you just turn it on like a car and go. So you have to wait for the chopper to warm up. They have to do the pre-check. They have to get the pilot. They have to get the medic. They have to go, and if it's raining or cloudy or they didn't poop that day, like they might not be going up. So you have like all of these other factors that are out of your control where you could just be like, listen, we're just going to take it swiftly but easy to the hospital, right? That's different though. That's a retrieval. So were they going? Peconic they were picking up from Peconic, or they were? Yeah, that's basically you're going to a higher level of care, and Northwell can do what they want because they have their own chopper. Yeah, so retrievals are a little different because they're also charging that patient. They're charging that patient. They made a lot of money on that, so. Northwell wasn't crying the blues, and they probably had that chopper up and ready to go. Well, that's the ideal, and that's the ideal setting where, you have somebody who's like, okay, they're entrapped in this car and you know that they have a significant injury. We need to get them to the hospital quickly. You have time to get the chopper up and the chopper where you need it to be, and you get to the landing zone. You're not extending the transportation time at that point. But it's, when you see CI Hop Hog, who's 15 minutes away from Southside, or 15 minutes away if you boogie, because I've seen some people do it, 15, 20 minutes away from Stony Brook, calling for a chopper for a patient who has like a broken femur or something, and they're sitting around waiting at the landing zone for 10, 15 minutes waiting for the chopper to arrive. Like, just go to the hospital. Why are you sitting around? Is kind of, I guess, people just, that mentality of like, oh, we should get a medevac. No, just go to the hospital. This region, like that central Nassau, central Suffolk kind of region, does not really benefit, unfortunately, from helicopters. And it makes everybody sad because everyone just wants to play in the helicopter. I get it, boys and their toys. All right, back to trauma. So kinematics is this really kind of cool thing where we talk about when you see an injury and you kind of predict what injury, you see a accident and you kind of predict what injuries you're going to be seeing, right? So, if you have a ped struck, you're assuming that the patient's going to have tib fib and possibly femur injuries, maybe even a head injury if they bounced off the hood. If you have somebody who's a jumper down and they landed on their feet, you're going to expect, lower extremity injuries. If you have somebody who got their hand stuck in a lawnmower, you're going to expect, upper extremity injuries. So when you get the call type and you're on your way into the job, this is sort of when you start to predict what you're going to see. And there's a lot of different things that kind of factor in. So if you have a younger person who is hit by a car, like say 5 or 6, versus a 50-year-old who gets hit by a car, there's going to be completely different injury patterns. If you have a motorcyclist, right, who is wearing a helmet versus a motorcyclist not wearing a helmet, what was the speed? What other comorbidities were existing beforehand? What kind of energy was there, right? Was it thermal? Was it electrical? What other things were in play? So we're going to talk a little bit about that coming up. So, Newton's second law: energy can neither be created nor destroyed. It just is transferred. Okay. Unfortunately, most of the time it's transferred to the human body, and the human body can't handle that much energy, right? And this is what causes injuries. What kind of injuries are determined by what kind of energy happens, right? So if you have a patient who's in a fire, you're not necessarily the first thing you're going to anticipate is not going to be broken bones. Okay? If you have a patient who was, fell from the 3rd story, you're not going to expect them to be electrocuted versus, then experiencing just regular old trauma or blunt injury. And depending on what part of the body it's applied to is also going to influence, what you expect to see. Newton's first law, right? An object in motion remains in motion unless acted upon by an outside force. An object at rest remains at rest. This is pretty much everyone's rule of the weekend, right? Once you hit that couch, you're there and you're not moving. If you have been given a honey-do list and you have a lot of things to do, you're going to do that until you can be an object at rest. So if an object has a greater mass, it requires more force to change their motion, right? So if I'm going to come and I'm going to push a Hot Wheels car across the desk, that's going to take a lot less energy and force than if I'm going to push a Volkswagen, okay? So it also means that if I hit you with a Hot Wheels car, you're not going to get the same injuries as if I run you over with a Volkswagen, okay? So force is important when it's talking about trauma. The conservation of energy, right? We just talked about this. It cannot be created nor destroyed. It can only change form. So if you go from electrical, it can become thermal, right? If you are, if you have potential motion, it can become kinetic energy, right? There's a number of different ways that energy can be transformed. But when we're talking about trauma, most of the time you see it in chemical, electrical, or kinetic energy. Newton's second law: is force equals mass times acceleration. So, which means that if you have more mass, you will have more force. If you have a very fast, like a fast car, you're going to have more force. If you have, this is like where you have a Volkswagen moving at 90 degrees versus a Ford F200 or 250 or whatever they're numbering those things these days. You know, you're going to have a pickup truck versus a Volkswagen Beetle. That mass is going to be changed, which means that your force is going to be changed. Kinetic energy, right? Kinetic energy is, again, you're not going to be memorizing these things, but this is a concept that you need to kind of keep in mind, is 1/2 mass times the velocity squared, which means speed, right? So if you are moving very quickly, you are going to have a bigger, more kinetic energy regardless of what your mass is, okay? And this is why I don't know if this is up next. Nope. If anyone ever watched Top Gear back in the day when it was the original UK version, Jeremy Clarkson, Jeremy Clarkson, always say, speed doesn't kill, it's the cessation of speed that kills, right? You can move at a G, right? Like we go take astronauts and we spin them around until they experience a few G's of force, right? That doesn't kill them. If you slam them into a wall and stopped their motion at a G of force, that would kill them, right? So it's not the speed that you're moving that kills, it's the sudden stopping of the speed, okay? So just remember that. Which just kind of plays into a lot of MVAs because, right, so just because you are moving at 30 miles an hour, if you get hit by someone doing 90, you are still highly at risk because now that force and that energy is being transferred onto you. And your force at 30 miles an hour versus your force at 90 miles an hour is significantly different. Just things to keep in mind. This is also why it's important when you're doing an assessment on a trauma scene, like to find out about how fast someone was moving, right? And not always accurate, right? Oh, how fast were you driving? I was doing the speed limit. There, my ass, you were doing the speed limit. No one on Long Island drives the speed limit because when you drive the speed limit, you get tailgated. So, you know, I would say, it's like, you know, when you say, how many drinks have you had today? Oh, I've had 2. Yeah, the first and the last. It's sort of like, oh, what speed were you doing? I was doing 55 in a 55. No, you were probably doing 65. At least 10 miles an hour to whatever, in your head, to whatever speed that they say that they were going. It's probably a safe bet. So going back to speed doesn't kill, it's the cessation of speed that kills. Now imagine you're not wearing your seatbelt, right? And like this top one, right? This little dotted version, right? There's 3, well, we'll talk about that in a second because there's a good diagram that goes with it, right? But you will continue moving. If you're going 60 miles an hour and you suddenly stop, you are still going 60 miles an hour. What's stopping you? And most of the time, if you're in a car specifically and you're not wearing a seatbelt, that's going to be the steering wheel and the dashboard, okay? And probably a little bit of the windshield as well. Now, this is why we wear a seatbelt, because it kind of creates a cushion, right? It sort of gives you a little bit of stretch, and it keeps you with the car. Because once you become... Chris, mute. Once you become a free-moving object in a car, you have your own velocity. If you are attached to the car, you have the same velocity as the car and will therefore stop when the car stops. More about that in a little bit. So, blunt trauma. There it is. Speed has never killed anyone. Suddenly becoming stationary. Always listen to Jeremy Clarkson. He knows what he's talking about. So, blunt trauma, right? This is when an injury is caused by usually a change of speed, usually deceleration, and there's a compressive force, okay? So, it could be you're being hit by a baseball bat, you are in a car that suddenly hits something and comes to a stop Um, the it also can be, okay, you've sustained blunt trauma because a wall fell on you and you're being compressed underneath it, okay? So you can have a number of different ways that blunt trauma happens. The injury will depend on a number of different things. So if you're being hit with a baseball bat versus, say, a cricket bat, right, where the cricket bat's a little more broad, you're going to have worse injuries with the baseball bat because it's compressed, right? The area is focused where the force of compression is being applied. If you are under a cement wall for 10 minutes versus 20 minutes, you're going to be more injured. And what's being compressed, right? Is it a area that is like the lungs, for example, where it's full of air, or is it a solid organ like the liver, okay? So these things are all different factors that you need to take into consideration when you're assessing your blunt trauma patient. Motor vehicle accidents, right? So there are 4 different impacts that occurred during an MVA. So the first one is that the vehicle strikes an object and comes to a stop. Then inside the car, the occupant will collide with the inside of the car. If you were wearing a seatbelt, this becomes less of a separate impact because you are now, remember, attached to the car. However, now your internal organs are still moving at 60 miles an hour, for example, and they will now collide against various body parts, bony structures in your body. And then my favorite part is the unsecured objects in the car. Now, tell me, people, how many of y'all got crap in your back seat? Like, I think we're all guilty. Don't join a bowling league, okay? Because, like, if you ever get in an accident and you have a bowling ball in your back seat, it's going to be, like, the first thing that kills you, right? Keep it in your trunk. If you happen to have a vehicle with a trunk. This is like one of those things where it's like, okay, you made it through, and then you get hit with something that happens to be in your back seat. This is why in the ambulance, we make sure that all of our stuff is secured to something, right? Right? We don't want like a 30-pound monitor come flying through the separation section of the ambulance to come kill us. That would be unfortunate, especially because you would probably get a write-up, even though you've been traumatically injured by like a 30-pound life pack. Like, you know that your supervisor would be like, hi, yeah, we're going to give you a write-up because you didn't properly secure this. And you're like, really? Just keep that in mind. This literally happened. The Reeves stretcher, we had not put our Reeves away when I was in my accident, and it had gone flying forward. It didn't hurt anyone, but it was unsecured. And like, the supervisor was like, I need to ask you why. I'm in the ER, mind you. Why was the Reeves stretcher not under the bench seat? And I'm like, really? Not the time. So remember, secure your stuff. So depending on what happens during the accident is going to depend on what injury, or I guess the accident is going to depend on what injuries you see, if there's restraints being used. Older vehicles versus newer vehicles. I know everyone's like, oh my God, like you hit a squirrel and your car kind of crumpled. Those things were put in place for protective measures because back in like the 70s when you were driving like the Chrysler Cordoba, and yes, my parents used to own one, the thing was a land boat. Like, it would weigh like 3,000 pounds and it was made of pure steel. If you hit it, it wasn't going to have a dent, but you were going to be injured because now that energy like isn't being diffused. That's what crumple zones do. It diffuses the energy so you are not as impacted by that energy transfer. The same thing with airbags. Though, everyone makes fun of me because if you ever get in a car with me, I'm 5'3"-ish, maybe on a good day if I stand up tall. I drive far away. Like, I drive full straight arm away from the car because within 18 inches of the steering wheel, you will be more injured by the deployment of an airbag than you will by the accident itself, because an airbag's moving at about 220 miles an hour, right? So you're going 60, it's going 220, and you're meeting in the middle. And I wear glasses, so I'm definitely going to smash those into my face. Done it before, it sucks. So everyone makes fun of me because I drive with like my tippy toes because I don't want to get crushed by an airbag. So just things to keep in mind, especially if you see someone who, those little tiny like girls who drive like a Honda Civic and they're sitting on the steering wheel like this, they're going to die, okay? They're going to take the airbag straight to the chest and just be imploded, okay? It's just not going to be a good look. I don't know why people drive like that. Like, when you're driving with your chin, sit back. It's good for your posture. Okay. So, of the different impacts that you can experience, number one, the head-on impact. This is a sudden, abrupt stop of motion. This is frequently one of the more deadly impacts that you can experience, because you're just taking all of that energy and all of that force directly onto the body. If you are not wearing your seatbelt, there are two pathways that a human body will take in a head-on impact: the down and under, or the up and over. Pictures. So, the down and under is when you kind of, I guess, armor-rolled your seats really well and you're just going to slide right under the dashboard. So, common injuries that are seen are knee dislocations as they hit the dashboard. So you have that right there, right? He's hitting the, let me get my little pen. I enjoy my little pen. So you got, right here, you got the oh, I don't like that color. You've got knee dislocations, it's still green, down here, okay? Now, this energy is going to be transferred up the leg, so you're going to have potential issues in the femur and in the hip, right? Because the hip is not designed to kind of just go straight back through your pelvis, so you're probably going to have potentially a pelvic issue here in the sacral region. You'll potentially have a dislocation or a fracture at the hip, okay? And remember that there is a lot of very vascular structures and major blood vessels running through this general pelvic region. So once you start adding sharp bones to that area as they start to crumble, you have a very high risk of hemorrhage, okay? So that's your first option, is the down and under, okay? Your second option is the up and over, which is, I want to say, probably more common, because I don't know about anybody else, but if you think that you're about to get into an accident, you kind of slam on the brakes. And this is why drunks don't die in a car accident, is because they're just so loose. They don't have that like fight or flight response. But you'll lean forward and you'll kind of slam on the brakes, and as you slam on the brakes, it's going to propel your foot. You're creating a pivot point, and you're going to move your whole body forward. So the up and over is probably a slightly more common injury pattern that you're going to see. But just wear your seatbelt. So things that happen is the torso impacts right here with the steering wheel. There have definitely been patients who've had like the little Honda logo or the Mercedes-Benz logo imprinted onto their chest. Things that you'll see are going to be rib fractures, right? So you have some ribs, the diaphragm, depending on what point during the respiratory cycle that the patient is during the accident, when the pressure is applied to their chest. So you might have a ruptured diaphragm. You could have a pneumo, right? A pneumothorax. It's not on this list, but a pneumothorax from the pressure. You could have a hemonoma. Pulmonary contusion, which we actually, I'm going to tell a story about that in a second. Cardiac contusion, right? A contusion is just a bruise. If you're having a really bad day, you could actually have a myocardial rupture. Your patient's going to look really not stable, right? If your heart literally explodes. Vascular disruptions and a head spinal injury, right? Because as you decide to exit the car in this general direction, your face is going to be birthing itself through a windshield. Just not a good look. When it comes to vascular disruption, so your heart, remember we talked about this before in pediatrics. Here's your heart, and we're going to do it anatomically, Hardy. Here's your aorta, right? And then there's that blanking on the name. Venous arteriosus, right? That turns into this little ligament. And that's everything right there, right? You have your pulmonary vessels. That's what your heart's hanging from. So if your heart Imagine right, this little yellow dot is the heart. If your heart is now suddenly going from hanging in like a really delightful fashion to swinging forward against your sternum, this right here is a very vulnerable location. So you can have a sheathing here at the aorta. This ligament can literally just slice right through the aorta as well. This is where you end up with a lot of like your traumatic arrests, is because the heart, which is a few pounds of weight, is swinging against this aorta, which is not designed for that much momentum. Okay, so that's where you end up with those patients who are just traumatic arrest, and you're like, what happened? Like they slammed against the steering wheel so hard that their heart was just whoosh and just disconnected. It's like a decapitation for your heart. Lateral impacts. So lateral impacts can cause significant injuries as well, but in as obviously a slightly different fashion. So your head is designed to kind of go forward and backwards. It's not really designed to bobble. So if you suddenly apply force, that's going to cause a lot of like that whiplash or a strain pattern along the neck, which is always fun. You're also creating a lot of force at the lumbar region, right? Because remember, your lumbar region's not attached to anything, so it's just going to go whoo, off to the side, and now it's being kind of anchored by your ribs and by your pelvis. And then you can also end up with whatchamacallit, like arm and like lateral femur injuries, depending on how much intrusion occurs in the vehicle. And now we have those side curtain airbags, which are really helpful in reducing a lot of these injuries. Seatbelts are always great, right? A number of different injuries that you may see, right? Your head, neck, clavicle, ribs, pelvis, depending again on where the impact is. Because if you are taking the impact of a Volkswagen into a lifted pickup truck, you're probably going to be okay. Liver, spleen. Again, sometimes the seatbelt can also cause some injuries based on the location, especially in little kids. Because if you don't have a little kid in a booster seat, that seatbelt's going to dig into their neck and can cause a lot of like injuries in the neck. Rotational impact, right? So you started driving straight, you got hit in that sweet spot, and you started to spin. Unrestrained patients are going to have a significant injury patterns in this because they're not going to stay in one location. They're going to move around within the vehicle. You're going to have a lot of the same injury, like a combination of the injuries that you're going to see in head-on and lateral injury accidents, because again, you're kind of producing both potentially forward head-on impact as well as that side injury. So you have a lot of neck rotational injuries, as well as potentially flexion injuries. Because remember, your center of gravity is here with your big old bobble head. Rollovers. Rollovers are potentially my favorite. Yes, they're very dramatic, but if you happen to be a restrained passenger and there's nobody else, they actually are some of the most survivable accidents, because if you think about, here's my pretend car, right? So you're driving and you're going, and all of a sudden you get hit, or you hit black ice, or whatever happened to cause your vehicle to roll. Instead of suddenly stopping, you're rolling, right? So now you're just dispersing energy across the environment, which means that if you're restrained and you're moving with the car, you're not going to have serious injuries because there's not a really large dispersion of energy to you as a human. If you are unrestrained, you're screwed. I can't help you. Rollover, unrestrained patients in rollover vehicles very rarely remain in the vehicle. There's a fun YouTube rabbit hole for you to go down if you want to watch people go flying out of their vehicles during rollovers. Things that can happen is like if you can still have a number of injuries depending on what if your windows are open and your arm goes out or your head goes out of the car, that could be troublesome. It could be any sort of injury pattern as well, because it really depends on restraints or not, what's inside your vehicle, right? Because that's the time that bowling ball will kill you. Restraints. They're very, very good. They're very helpful. Safety seatbelts reduce the risk of fatal injury by 50%. You are 30 times more likely to be ejected if you are not wearing a seatbelt, and 75% of those ejected people die. Hey, 25%, that's me. Lap belts, not as effective as the across the 3-point, where you're putting it across your chest as well, because it will transfer all the energy into your pelvis, which can be good because your pelvis is a strong bony prominence. However, if it's worn too high, it can cause significant damage to your abdominal organs, as well as transfer a lot of energy into your lower back. It does not prevent the motion of the torso, right? So you kind of end up with like that forward issue, where your shoulders and your head, etc., are going to kind of be in a free fall spin. This is the most standard seatbelt that we see, is the across the shoulder strap. New Zealand did a really great public service announcement where they actually had survivors of car accidents who were wearing their seatbelt show their injuries, and most of their injuries were seatbelt bruising. But they were like, if they had not been wearing their seatbelt, they would not have walked away from the accident. They were trying to encourage more people to wear their seatbelts. Apparently that's a thing in New Zealand where people don't wear their seatbelts. It does help keep that torso in the location where it needs to be, but it needs to avoid the neck. And this is the problem with small children wearing the across the shoulder strap, is that if they are not in a booster seat or they're too small, it can cause a lot of damage in the neck region. Airbags. We talked about these already, right? They can be deployed at about up to 220 miles an hour, and this is why we put young children in the back seat. They're very specific. I don't know if anyone's ever seen, like, you kind of go up to a seat and you're expecting all the airbags to be off, like, have gone off, and, like, nothing happened, and you're like, wow, that's wild. There's apparently very specific sensors that need to be hit in order to actually deploy the airbags and or the side curtains. Meanwhile, you have somebody who's barely gotten hit, and like they hit that sensor and every single airbag went off. They're kind of designed to help cushion that forward motion and reduce that sudden stop, right? Because that's just the whole idea. You're now, instead of compressing a steering wheel with your chest, you're compressing air. Child safety seats. A good number of people do not use these correctly. So infants and toddlers can have a lot of their lives saved in car accidents if they are properly strapped into their safety seat. Number one, the chest piece needs to go into the chest. It needs to be across the sternum, because babies, remember we talked about this, babies don't have a six-pack like the rest of us. We've properly hidden our six-packs. But if you put that chest piece across their abdomen or put it too low, you're going to cause that's going to cause significant internal damage if that comes to a sudden stop. And that's the problem, is parents are afraid that, oh, it's too high, it's too tight. No, it's not. The baby is okay. It needs to be appropriately positioned. Rear facing, right? Until that child, think about old enough, they've actually changed the rear facing rule. They've made it older. I think it's up to about 18 months or more now. Someone fact check me on that one. But basically the child needs to be able to control their head and have a strong enough neck before you can put them in a forward facing car seat. Because again, big old pumpkin head. You hit the brakes and that pumpkin head's going to bobble forward, and you're going to have a kid with all sorts of neck injuries. Again, look at where, in this second picture, look at where that chest piece is positioned across the chest. It's not down low, it's nice and high. As a child gets older, they can get moved to the booster seat, and then there's a certain weight and height that a child can be moved into a seatbelt. There's some adults that I know who still should probably have a booster seat, but that's neither here nor there. It is 2 years old. I was close. There you go. So remember, now we're trying to make sure that we're protecting those big old bobbleheads, because they don't exactly have like the musculature of the rock to keep their neck from bobbling all over the place. Internal decapitation is a huge problem with little kids because they have a very stretchy spinal cord and a very stretchy spinal column. So if they're put into that forward-facing car seat too soon, you can cause all sorts of problems if you happen to get into an accident. So they talk about the deceleration injuries. We talked about this a little bit with the heart. So as you move, as the car stops and then your body stops, everything inside your body also comes to a stop. Your organs will continue moving. So a number of different injuries that you may experience, right? So we call this the coup contra coup injury, where the force is applied, and as you move forward, your brain goes, okay, we're going forward too. And then it bounces against the front of the head. And then as you come back and the energy is moving in the opposite direction, your brain then bounces against the back of your head. This is very commonly seen with patients who have concussions after car accidents. Just remember, there is this like level of cushion inside your skull, as well as, inside your thoracic cavity, where things can go bouncing back and forth. In the event that you do see a patient with a coup contra coup injury, right, you need to make sure that they have their spinal cord, their cervical spine is properly maintained, with a rigid collar, because you could have some level of stretching, and if it's really bad, that can also cause swelling of the spinal cord. So here's the heart. Here's that ligaments arteriosum. Remember we talked about that? So this part right here, as the heart swings, let me get my little pen. As the heart swings forward, this doesn't move, so it creates, and this is attached to the aorta, and this has a motion in the opposite direction. So the heart's going this way, and the ligamentum arteriosum is going this way, and it just causes a tear. Okay, so that's where you might see your traumatic arrest, is because they've bled out right here from the deceleration motion. The descending aorta, so here's the ascending aorta goes this way. You look at this picture, it's coming this way. The descending aorta is anchored against the thoracic spine, so that's not going anywhere. But the heart is. The heart's going that way. So that's what causes a lot of the deceleration injuries in the thoracic region. Similarly to the ligamentum arteriosum, we have the ligaments in the liver that cause the same injuries, right? So you have the falciform ligament. Oh, nope. Undo. The falciform ligament. Come on. Now you're just being sassy. The round ligament, you have a number of ligaments here that can actually kind of slice and dice the liver, sort of like a cheese, if you're cutting cheese with one of those cheese knives, the little thin piece of wire. It's kind of the same thing, right? You have this very very firm ligament that is against this very squishy organ. It's going to cause a lot of issues. Again, a lot of potential for to bleed out, and the spleen can also be significantly injured. Now you don't want to go forward. All right, compression injuries. Any part of your body may be compressed, so just be prepared for injuries almost anywhere. Smushed heads, or head injuries, right? So if you significantly hit the head, it can result in a number of different fractures, open, closed. You can have brain contusions, bone fragments that actually penetrate the skull into the brain itself. Facial traumas are significant. Cervical spine, right? So it's a very vulnerable region. If you look at this guy, he pretty much sliced his head right open. This is a wild image right there. So cervical spine injuries, right? So you can compress the vertebrae, you can hyperextend, you can hyperflex. So you can have muscular strain in the front, you can have muscular strain in the back, okay? Compression fractures can require a significant amount of force to actually kind of crush the vertebrae. You'll see that a lot in diving accidents. I think Danny had this guy. There's a lifeguard who dove into the pool, hit his head, and actually gave himself compression fractures of the cervical spine. So he was like 17. So it just requires a significant amount of force. What else? Thoracic injuries. That's a heart. In case you were wondering, they're doing a bypass to kind of help fix a ruptured heart, a ruptured ventricle. Obviously your lungs and your heart are pretty much the primary organs in your thorax, and two, very vulnerable. Ribs and sternum, if they are fractured, especially ribs, can cause a lot of injuries to your lungs in particular. Pneumothorax or paper bag lung injury, right? That's why sometimes if your patient takes a deep breath and holds their breath as they are being compressed or suffer from blunt trauma, you'll potentially see their lung has exploded because of that pressure of the air inside their lungs, creating that explosive force. Compressing the heart between the sternum and the spine, right, which is what we kind of do during CPR, but can cause all sorts of other contusions or other ruptures, as seen here in this fun little picture. Solid organs, right, your spleen, your diaphragm, and your liver are at risk. Again, it depends on potentially where the patient is in their respiratory cycle. So if they're getting hit in the stomach, but they have exhaled, part of their livers may actually be protected by the rib cage. If they're in a full inhale and their liver has dropped, they're going to be at an increased risk of liver injuries, diaphragm injuries, etc. Vascular organs such as the liver and the spleen, very high potential for hemorrhage. Hollow organs, especially the intestines. Remember, the 1 trillion bacteria, if any of those rupture or become perforated, you have a very high chance that patient's going to go into some significant sepsis. Farming is super dangerous. I don't know if this is still available on Netflix, but it's called 1 Hour to Save Your Life. It was a documentary of the UK Emergency Medical Services. And those guys know how to use a helicopter, first of all. They have a lot of rural areas in the UK that are still very significantly farming areas, and this guy actually got crushed between a wall and a cow, and he lacerated his liver, and he's in the middle of nowhere. Mind you, cows, we're like, oh, look how cute. They're like they're like a ton. They're like literally like 2,000 pounds. Oh, moving wall. So he got crushed, lacerated his liver, was in no good shape. And they show up in the helicopter and they start trying to like stabilize him a little bit. They totally snowed him with some ketamine. And then they gave him TXA, which is the opposite of TPA, which is kind of cool because they use that. They have a lot of physicians actually writing EMS in the UK. So TXA creates clots. So they were trying to prevent him from bleeding out from his liver laceration as they loaded him into the helicopter and went to the trauma center. I don't know if it's still up and available, but it was a lot of fun. It was a really fun series, and it was like probably a little better than like Night Watch because it was a little less American, I guess. So farming, super dangerous. A lot of really wild machinery. If you could see this guy, he got his arm stuck in an auger. Silos, very dangerous. A lot of the time, farmers in particular end up working alone because farming seems to be kind of dying in so much as it's not like you have a whole bunch of people out there in the field with you. So the delay to getting an ambulance because you're trying to get your arm out of the hay auger or whatever can be deadly. Motorcycles and bicycles have very similar injury patterns. So you'll have, especially if the handlebars are in that particular location, if you come up and over, there's a significant possibility for bilateral femur fractures. Little kids right? So little kids, again, going back to not having a very good abdominal wall, little kids going into handlebars, right? They end up right into that liver. So they will have pretty gnarly abdominal trauma if they do happen to, I'm tangled, sorry. If they do happen to go up and over their handlebars on their bicycle. Helmets are super essential on motorcycles. I know they have those little DOT approved ones that are just the skull cap. I don't know that's going to do for you if you happen to like go up and over your handlebars and rub your face against asphalt. The full head covering is probably the best course of action if you're going to ride a deathmobile here in New York. People who ride motorcycles in like the Long Island region are some of the like crazy bravest people I know, because you literally just, people drive terribly. So like, if you're going to drive a motorcycle, you should do it somewhere where people aren't trying to actively run you over. Just seems safer. A lot of motorcycle riders are or more experienced ones are very skilled in what's called laying the bike down, and they will actually it's sort of like just walk away. Like they'll be able to kind of control the issue. Angular impacts, right? So if you're the motorcyclist and somebody is either making a turn into you or something to that effect, the injury is more of like a compression injury, or they could get like things like their leg stuck between the car and the motorcycle is a potential issue. So there's a different pattern of injuries that you could potentially see there. The problem with being a motorcycle rider is that you are not exactly well protected. Laying down the bike, I just talked about this a little bit, right? So you are removing yourself from the force and the mass of the motorcycle. So that will continue forward, because you have much less mass, you will not sustain as much injury. The problem is usually the leg that, if they're not good at laying the bike down, the leg that's between the bike and the road can become kind of banged up, broken, road rash, right? Don't ride a motorcycle without like long pants and a leather jacket. Like, it's not just a statement, like it's actually protective. Pro tip, don't be on a motorcycle if you are wearing a spaghetti tank and booty shorts and flip-flops. Had this girl, she was all sorts of messed up. It's just not a good look. She was made of road rash. She had like 6 different broken bones, and she was AMS because she wasn't wearing a helmet either. Like, I don't know what goes through people's heads sometimes, but that's not appropriate riding wear. Meanwhile, you see these other guys who got like the full like body plates, and they're set and ready to go. Those guys will walk away like, I'm good. And you're like, yeah, you are, because you just spent like $500 just to protect yourself. That's wise. I don't know. They do. So you may be a little dazed, but otherwise, yeah. They also have what looks like a Victorian collar for bicycle riders, which does a similar thing. So like it just like, if it senses that you're falling over, it goes poof, and it just like. They also have another thing, which is like side bags, like on your hips, like the old Victorian hips where they kind of come out and like do the full for the elderly. So it has like a sensor, so as the elderly start to fall, it goes poof, and they'll land on an airbag, essentially, and it's supposed to help reduce pelvic fractures. You look ridiculous, but I guess you're not going to die. Yeah. So, anyway. ATV crashes, because ATVs have such a high center of gravity, they tend to flip and then tend to pin people. People are also kind of assholes when they drive ATVs because they think they're super cool. so they pull a lot of stupid stunts with them, and especially if you're riding them on rugged terrain that you are not prepared for, you're too inexperienced to deal with, there's a lot of injuries. A lot of the times you go to put your foot down, because remember, you're used to kind of driving a car, so you're looking for that brake to slam, but ATVs and motorcycles are geared in the handlebars, or the accelerators in the handlebars. So as you go to slam down on the brake, you get your leg stuck. Neck injuries. You can have a lot of other injuries that's related to compression, right? As you have like a 300 plus pound ATV laying on your body. Ped struck. Number of different reasons or different injury patterns that you can have with a pedestrian struck. It depends a lot on the patient's height, the car height, and the speed of the car. So if you are a adult and you get hit by a Civic, you're going to have a lot of lower extremity injuries. If you're an adult and you get hit by a 2016 4Runner, and I say that because their bumper is a lot higher, you're going to have a lot of like pelvic and maybe thoracic injuries. So it's really important to see what kind of vehicle is doing the hitting in comparison to the patient's size. And this also is important because we're going to talk about how kids react differently than adults. The other issue, so if you get hit by a Civic, there's a strong possibility that you're going to do a full-blown head into like a head into windshield or head into hood, depending again on your height and the car's height as well as the speed. This also means that you could potentially go up and over the top, which has definitely been occurred, right? Depending on, again, the speed of the car, because if you take them out low, that's going to make the body go up. If you take them out high, right? So if I hit you here, you're going to go forward. Again, this is all pretty, I guess, common sense in terms of injury patterns that you're going to potentially expect. But you need to kind of make sure that you think about these things when you're assessing the patient. And you also need to make sure that you assess for the fact to see if the pedestrian was struck by more than one vehicle, right? So if you get thrown out of the crosswalk into oncoming traffic, you could be doing a full-blown roadkill vibe where you're getting, thrown into traffic and then waffled by another car. So these are things that you need to kind of take into consideration. Now, the difference between adults and pediatrics is that kids don't have the same, I guess, defense mechanisms that adults do, where a child is going to turn and like embrace the car. So they're going to be like, I'm running, oh, the car! And they're going to have a lot of like chest and abdominal trauma where an adult is going to turn away. Okay? That's a pretty significant difference between how you would expect the injury patterns to go. Also, because children usually are much lower, they're most likely going to get thrown or they're going to get pulled under the car. Because remember, the car still has to stop. So there's a strong possibility that that small child is going to go underneath the car. You have a hot engine, you have a lot of hot other components underneath. That can cause significant burn injuries and stuff like that. Give me 2 seconds, I gotta close my door. Yeah. Okay. Other fun injury patterns that you could see, which is a kind of blurry, unfortunately, is the best version of this picture I could find. I particularly enjoy mechanism 3.2, where it looks like you were actually hit by a WWE wrestler and head slammed into the ground. I don't know in which world you're going to be putting your feet on top of the car, but I enjoy it. It's fun. Sports, as much fun as sports are, they also kind of involve potential injuries, especially high velocity and contact sports. Water sports are their own kind of vibe because people do a lot of stupid things on boats, such as drink and blank, right? So you're drinking and boating, you're drinking and water skiing, drinking and jet skiing. It's just, you can still get just as hurt, okay? Like, you drive your boat into a rock, you're still going to get flung. Similar injuries, right? You have your acceleration, deceleration. Um, Compression injuries, sometimes the twisting injuries are an issue, especially if you're going at very high speed and one part of you stops and the rest of you keeps going, as seen with a lot of knee injuries in like soccer and football. Blast injuries, we talked about this earlier in the course when we were talking about weapons of mass destruction. A problem with blast injuries is that it's multifaceted, right? So you have not only pressure injuries and heat injuries, but the potentiality of projectiles and fragments, right? So you have patients who have potentially very mutilated, distracting injuries in their lower extremities or their upper extremities, like fireworks, for example. But if it was a significantly large enough bomb, they could also have compressive forces that caused by pressure, right? They might have a blown eardrum, they might have a pneumo, so you can't get distracted by some gnarly looking crispy extremities. When it comes to explosions, right, we have and we talked about this again previously, so this is just a bit of a refresher. You have primary, secondary, tertiary, and quaternary and quinary, we could throw that in there, levels of injuries. So the very first, being primary, is created due to the blast, right? Due to the explosion. So you can have eardrum ruptures, hollow organ ruptures from the pressure. You can then you have your secondary, where you have where fragments or other flying objects will cause blunt and or penetrating injuries. And then you have tertiary, right? So your body, the patient's body is thrown against the wall or the ground, which can cause head injuries, other blunt injuries. If like a wall or something kind of falls onto you, you could be experiencing crush injuries. Then you move into your quaternary, where there's burns or inhaled toxins, or even upper respiratory burns, secondary to hot gases that are in the environment. And then you have quinary, so if it happens to be a dirty bomb, that's like a quinary level injury from an explosion. And then, in case you were wondering, there's always the potential for PTSD. Extra fun. So you have vertical falls, right? Moving on to different injuries. Vertical falls is really dependent upon the distance that you have fallen. If anyone remembers as a kid, if you've jumped from something high and landed on your feet, but you didn't land quite right, you get that shock in your heels. So that's usually where the initial impact is, and then it goes and gets transferred up into the pelvis. So your jumper down, who has decided that 3 or 4 stories is enough, and they jump and they hit feet first, you're going to see, the shearing fracture through the pelvis. You could have compression fractures in the joints at the knees. And that energy is going to kind of vibrate all the way up the leg. So you could have fractures anywhere along this region. Say that again? Yep. Yep. Can I explain it, or is that a possibility? Say that again, like that I've had more or less coffee. The possibility, yes. So as the energy moves up, if the joint here happens to be weak, there's a very strong possibility that it will come out. Okay. Most of the time, there's just driving force upwards, so it just, instead of it coming out, it just pushes the pelvis up. But there is a possibility that it can go up and out. Back to kids, right? Kids are still big old pumpkin heads. They're probably going to fall straight on their head, just because of the sheer force of gravity. Like weebles wobble, but they don't fall down. Kids fall down head first. And the type of surface body that is landed on. So concrete is going to be less forgiving than grass. Water, if depending on the height that you fall from and how you hit the water, like if you belly flop onto water, it has the same surface tension as concrete. if you hit it with like feet first, where you're kind of breaking that surface tension, it's not as dangerous. That's why people can do those high dives without getting hurt. But belly flopping from very high concrete. Penetrating trauma. All right, so this is anything where there is a item going into the body. Cavitation. So when you are, even if it's, most of the time we kind of associate cavitation with a bullet. What happens is as the force goes through the body, it pushes the tissues away, right? It has this like pressure field that surrounds it, because it's not just the projectile that's moving through the body, it's also air, right? Because it's kind of being sucked in the wake of the high speed of the bullet. So it starts to create this pressure force, and as it does, it pushes all the tissues away, and then it kind of comes back. But there's this permanent cavitation. So the larger caliber of a bullet that goes through is the larger cavitation that's going to be there. And that can create a significant amount of injury as well, because now you're causing damage to tissues through the pressure wave. And as that goes through, it can create a really great opportunity for bacteria and other tissue necrosis, etc., that can cause a lot of infection and issues. I do. Let's see if this will. Oh. Curses. Stand by. Let me see if I get the video to play. You know what? I'll just send you that video. It's a really interesting video that actually shows you how cavitation is formed in gel, in ballistics gel. So ballistics, we talked about force and velocity. So if you have a small bullet moving at a very high velocity, they can potentially cause a lot more damage than a larger caliber bullet traveling like slower. Okay, the interesting fact about small caliber bullets is once they enter like a body cavity, they tend to lose a lot of momentum, which means that they sort of kind of ping around instead of exiting out the other side, whereas a larger caliber bullet just keeps going. So you can have a patient who has, been shot by like a 22, where they get shot in the head with a 22, they could have like all sorts of scrambled brain kind of vibe because it's bounced around inside their head, versus if they get hit with a 9mm or something larger, where it's going to go straight through and through and leave a huge cavitation in its wake. We like to classify our projectiles by their energy level. So low energy is like knives, ice picks, anything where you have to do a stabby, right? So like it's being propelled by the weight of a human body. Fun fact, women tend to stab like this, and men tend to stab like this, versus this. Women are very tricep strong. We get a little more oomph out of this. Also, we tend to be shorter. So, like, I'm not going to stab you in, like, the leg. I'm going to go for the emotional high point. It's one of those fun little CSI kind of vibes. So, if a projectile is being fueled by a heavier individual, it's going to have more, it's going to create more damage than if it's, it's being fueled by a less massed person. Your medium handguns, some rifles, anything that goes less than 1,000 feet a second is considered a medium energy level weapon. A high energy level is at greater than 2,000 feet a second, so some of your more potent rifles. Yaw and fragmentation are two things that kind of need to be taken into consideration. So when you shoot a gun, it's supposed to have a certain level of spin on the bullet that keeps it going straight. What happens is there's oxygen molecules and other molecules in the air that actually kind of take it out of that spin, and as it goes and it kind of wobbles, it creates what's called yaw. So if the bullet has been shot from a significant distance, it's not going to have that very tight spin on it, it's going to have a lot more yaw, and it's not going to create as much damage as if it was shot up close. Fragmentation also, right, depending on what kind of bullet is being used, right? There's some bullets that explode more or less upon impact. It's going to cause a lot more damage than something that remains intact. This is really trying my patience right now. I don't know if anyone saw this. Again, I'll just send you a link to it later. This gentleman actually got shot with a .22 right in like the corner of his eye, and GCS was 3. There was no exit wound. It just like ran along the outside of his skull, which was pretty wild. Shotguns are always fun, depending on what's being used with that shotgun. It's either going to cause a really big hole or a lot of little holes, right? Buckshot and birdshot are going to be a lot different than shells. So you could potentially, and also if the shotgun's been sawed off or not, right? So a sawed off shotgun is going to have a lot wider spread, but it ends up usually having a high risk of infection because there's just so many little holes and there's so many projectiles that now need to be removed. Come on. Thank you. So we talked about cavitation. Cavitation is also the reason why an exit wound is going to be so much larger than the entrance wound, except for .22. The .22 stays pretty same. But the larger the caliber, usually the larger the exit wound because of it's propelled. The wound is being forced and propelled by cavitation. Up close, you're going to have a lot more of a significantly sized exit wound than from further away, because it's moving so much faster. A lot of different things will affect it. You are not going to be performing a crime scene investigation on it, so you don't have to really know a lot about this, but do understand that the patient may have been shot with a 9mm, and you can expect maybe just find, a small entrance wound and a slightly larger exit wound. Just also recognize the path between the two, right? Because if it's a straight path, it's a pretty straightforward kind of potentially injury pattern. If it's not, maybe it hit a bone and bounced, you could have a lot more injuries underneath. Traditionally, suicide by gunshot wound to the head is pretty fatal. Not 100% successful, though. It can, especially because most of the time the gun is held very close to the head. It will cause, a larger cavitation and a lot of swelling to the brain and could create a very significantly challenging airway. But if it's a smaller caliber, or if the patient kind of flinches and pulls away, you can end up with someone who's still alive and breathing. So you need to make sure that you assess your patient appropriately. Jody can attest to this one. Make sure that if you have a patient who has a self-inflicted or otherwise gunshot wound, don't just go from the doorway, yeah, they're dead. They're not. Check. Most of the time they can actually survive that. If you have a patient who has gone straight through the mouth to the back, right? Your brain stem is right here. That's all your primal life needs. So if you have a patient who's gone like this, they've potentially just blown out their frontal lobe and their eyes. If they've gone straight back, they're probably going to be somewhat more successful. There we go. Gunshot wounds to the chest, right? So we talked about the where in the respiratory cycle the patient is. So if it's a lower thoracic injury, it could also involve the liver, the spleen, and the diaphragm, as well as the gallbladder and the pancreas. But if it's directly into the abdomen, it could go up into the thorax and create lung issues. If it's a direct hit to the chest, you will have to consider a hemopneumothorax. You're going to have to consider that there's cardiac involvement. And remember, you have a lot of space in here to hide a lot of blood. So you want to keep a good close eye on that patient's vital signs, because they could be hemorrhaging and you're not going to be able to see the blood. Abdominal injuries are always fun, and pretty much always require surgery, exploratory surgery. So if you've ever had a patient who's got like that nice long, like surgical wound that goes all the way down around their belly button and keeps going down, it's a very strong possibility that they've had exploratory abdominal surgery, because everything else is pretty much done laparoscopically these days, because they don't want to open up your abdominal wall, because it's just very difficult to kind of recover from. Not a lot of super solid organs here in the abdomen, so there's a very strong possibility that it could also affect the vertebrae if it's frontward facing injury. And also a lot of other organs can be involved. Extremity injuries, if they're up close to the body, right, those proximal injuries can be life-threatening because you have a lot of significant vasculature. Nerve damage and like long-term functional mobility is an issue. Bone fragments can go and create all sorts of wreak other havoc in the body if they happen to go get into the vasculature and float around. Again, we can kind of keep this under control, right? We know how to handle these things. Trauma activation algorithm. This is not used everywhere, but we talked about this earlier, that algorithm. Remember, it always leaves a section for the criteria for discretion. Okay, so if you're like, no, really, they sustained a significant amount of injury, like it doesn't look like it, but their car is, now a meatball, this is where you need to kind of speak up and be like, yeah, no, this is an issue. Okay, cool. Questions, thoughts? All right, we've got 2 more, whatchamacallit, slides. Let's take a 5-minute break. Come back in 5 minutes, stretch, get a coffee, do a pee. I'll see you guys back in a minute.
I did one for one of the Chabad Mineola, actually. I'm their medical director too, and they use the state stuff. The rabbi over there was awesome. He really wanted to get the word out back like about a year ago. He did a lot of stuff through the through the synagogue about it. So. Nope. No, everything from the state's great. They have some grant or something. I don't know where they get the money from for all of this. I think it's under some federal grant. I'm not 100% sure, but everything from the state is great. Yeah, again, I'm going to defer to you guys how you want to handle that since it's your project. I'll just provide whatever technical and knowledge assistance you need and make sure to facilitate all this stuff for you. And then Barry, like I said, any communications or whatever's going on, I'll just keep you CC'd so you're in the loop, and that way if you have any thoughts or concerns, just let us know. And I guess my other question, guys, do you have a time frame? Like, what's your time frame for this? If you want to get
I really should have remembered to actually pause the recording. Oops. We got like a 5-minute break of nothing in this recording. Ooh, do tell. Okay, what is the weapon? Nice. Was he scratching his head with the nail gun? Like, how does one do that? Mm-hmm. Jesus. Oh shit. Mm-hmm. And harvest his organs. Oh Jesus. Mm-hmm. Who is your partner? Oh Jesus. No, no, no. I was I know someone who worked for Live on New York, so or did. I don't know if he's still there. So, yep, that's fun. 100% not recommended. All right, is everybody back for the most part? I think almost everybody's back. All right. So, moving on. Next up, any questions before we keep going? Any other questions, thoughts, concerns? Okay. So, next up, bleeding and trauma. Let's do it. Bleeding and soft tissue trauma. Sorry. So, probably the biggest concern when it comes to bleeding is bleeding that doesn't stop. So, hemorrhage, right? So, external hemorrhage is usually kind of the result from a soft tissue injury. Most of the time, we can control it and it doesn't pose a serious life threat. However, it can cause death, depending on where it is and how much blood is lost. What's the source of a hemorrhage, right? An artery is going to be a lot more of a significant issue than capillary bleeding or venous bleeding. How many significant vascular structures are involved, and how much blood loss can the patient tolerate, right? So if you have somebody who is, just donated a pint of blood and then they get into a serious car accident and they are bleeding profusely, they're already at a loss, right? Internal hemorrhage can be an issue as well because you can't accurately estimate how much blood has been lost because you can't necessarily see it. You also have 4 really delightful body cavities where blood can hide. We talked about the chest, the abdomen, the pelvis, and into the thigh as well. Come on, go. So significant internal bleeding, right? So obviously bright red blood is always a really good sign or symptom of significant bleeding. Coffee ground vomitus, melena, right? So that dark, sticky stool. Any patient who expresses that they are having dizziness or passing out when they sit up or stand up, right? That should be like a high index of suspicion problem where you're like, that's not normal, okay? It could be that could be cardiac in nature, but it's it's a very good idea to consider it to be a bleeding problem first, because that can be managed, hopefully. And then you have orthostatic hypotension, where you actually witness the vital sign changes from a patient sitting up, growing from a laying down to a sitting up position. Quick review on skin, right? So we have 5 different layers of keratin in the epidermis, which is that thin most outward layer, right? Your epidermis is showing. There's no real vasculature here, right? You're not gonna, if you do like a really very tiny cut, you're not gonna bleed. You don't start bleeding until you start hitting the dermis. That's the part, like the really springy part of your body that has strength and elasticity, of your skin that has strength and elasticity. It has nerves. It has vasculature. This is like the healthy part. And as the cells of the dermis start to die, they get pushed up towards the top and they become the epidermis. And then you have the subcutaneous tissue, which is your the fatty layer that everyone should have, right? This is the fat we like. This is what keeps you warm. This is what provides you with a certain layer of protection from trauma, right? It's like that insulation and that little tiny fatty airbag that we all have. When you have an injury, and there's an internal and an external pathway for clotting, but it works very similarly. Your body recognizes that there's a broken vessel somewhere. It could be, exposed to the environment, or it could be somewhere inside of your body. And it goes, oh no, that's not good. So it starts to send blood to the area, and with that blood comes platelets and clotting factors. So the platelets and the clotting factors start to get all sorts of sticky, and they start to grab red blood cells to create a wall, essentially, which is the clot. And then as the broken vessel starts to grow new cells and close up the injury, then the fibrin starts to be broken down, and the clot dissolves. This is kind of cool. Your body has tension lines. So if you cut along a tension line, hold on, let me get my little pen. So for example, if you had an injury here on your arm and it kind of went this way, it's going to heal really well. Okay, you probably won't get much of a scar, because basically your skin is tense in this general direction, and it will actually pull the wound kind of back together. As opposed to if you go across the line, so like if when we talk about you have that abdominal, the exploratory abdominal surgery, and you go across, that's pretty much the way they do it, and they go belly button. That's not going to heal as well because it's pulling the actual parts of the skin apart. Just fun fact. Some of the more high-risk injuries that you may experience are obviously hands and feet, because, if they don't heal well, you're reducing someone's functionality as a human, right? We like our opposable thumbs. The perineum, right? We like our genitals to be intact. Bites, right? Because bites are a puncture wound that have very high bacterial content, so they're very likely to become infected. Crush wounds, because that can lead to compartment syndrome, which we'll talk about a little bit later. Any sort of injury that is contaminated with organic materials, right? So little kids who are outside and they run and they scrape their knee, but it's all full of mud, more high risk because it has an increased potential for infection. And anything that has been significantly devitalized. So degloving injuries, right, where it's been kind of like significantly removed from vasculature, amputations, those are all high risk wounds. Isn't that yummy? There's a number of things that can impact how well you heal. As we all know, diabetes is a huge problem in terms of patients' ability to heal. Liver failure, right? Because that's where your clotting factors are made. Any patient who has some sort of level of immunosuppression, malnourishment, because again, if you're malnourished, your body doesn't have the factors it needs to reheal itself. Cancer, anti-cancer agents, NSAIDs, because you do require a certain level of inflammation in your body to promote healing. It's part of the whole process. So any of these things can create alterations or a slowdown of wound healing, which could increase the risk of infection. Some patients experience abnormal scar formation. So either it's a keloid, which is excessive scar tissue that goes beyond the original wound borders, or a hypertrophic scar, which is excessive accumulation of the scar tissue but happens to be within the original borders of the wound. Patients who have wounds to areas that are extremely cosmetic, or they will almost always make sure that they do some level of stitching or closing it up so that it looks nice. It's like they're all about that, making you look okay. Significantly gaping wounds, anything that is across a tension area that is especially in the wrong direction, degloving injuries, finger injuries, all could potentially require stitches, or sometimes they use glue on the cosmetic regions so that it doesn't end up with like the extra stitch kind of look. A number of things can cause infection in soft tissue injuries. If the wound is left open and uncleaned for an extended period of time, it's a high possibility that they'll become infected. Crush injuries have an increased risk, as do anything that has been contaminated by organic material or feces, saliva, etc. And how the area has been prepared, right? So like you don't like tweeze hair out before a surgery, you have to shave it. And how it also dependent upon how much of the tissue area is located. Right? So if it's a significantly large wound, it's going to be at an increased risk of infection versus a tiny one. So if you look here, and this is really kind of interesting, talking about wound infection. So this patient obviously has a scar, or it looks like a surgical wound right here. But you can actually kind of see the very faint ink outlines where they have outlined the borders of her arrhythmia, right? That redness right there, this is all infected in here. They're tracking how far it's spreading, because if it continues to spread, that means that whatever they're doing is not working. If it starts to kind of come back in, it means it's getting better, obviously. So you might end up dealing with a patient who, you can see the initial like ink mark where they trace the outline of the infectious area. But you might see it's a little further, and that's not a good sign. Sometimes high-risk wounds, like if you've ever seen patients who they're like, oh yeah, no, I have this injury, and they're not closing it up yet, like sometimes they actually do leave it open to the air to kind of allow it to drain, which is weird and gross, but apparently really functional for wound healing. Sometimes they'll put a wound vac on it, which is like a gentle vacuum pressure that pulls debris and white blood cells and bacteria out of the open wound, which is always fun to see. Sometimes they'll do what's called a debridement. So like you'll have potentially this wound here, which is extremely infected, and they'll go in and they'll remove all the infected tissue, so it looks more like here, or B or C. Wounds that are extremely have a lot of drainage, or we call it purulent drainage, right? Or a foul odor, are not a good sign. Okay, if a patient is still like, oh wow, this really hurts, not a good sign. You can have a patient who just has a very red injury site with maybe no drainage, but it could be an abscess underneath, especially if it's swollen and painful. So you need to kind of be aware of what their pain level is, how long that injury has existed, etc., in order to, give a proper assessment to the hospital. Most of the time, soft tissue injuries are kind of a low priority. The biggest concern that you have to really keep in mind is that if you have a patient who has a significant contusion or hematoma, you could have an underlying fracture, or you could have significant blood pooling, which is, if they're on the hypotensive side, they could be bleeding out. A contusion is underneath the epidermis, while a hematoma is a little bit higher underneath the skin. So contusion's a little more spread out, where a hematoma is kind of more of like a lump. Like we call like the goose egg when you get on your head, that's a hematoma. Abrasions are kind of like road rash, right? Or you scrape or rug burn, or you just kind of rub off some layers of the epidermis. Most of the time it's kind of superficial, but if it's not cleaned properly, there is a high potential for infection, because it's just a broad open area of skin that's involved. Lacerations tend to be caused by a sharp object, but not all of the time. Sometimes patients can actually have a laceration from blunt trauma, where the pressure actually just splits the skin open. Lacerations tend to be on the cleaner cut side, where it's like you can very clearly see the edges of the wound. Puncture, always fun. Sharp object, usually a small entrance wound, sometimes a larger entrance wound, depending on what's going on. But there could be a significant underlying injury. Right? It depends on the weapon, if the weapon was clean or not, right? Does anyone remember, like, as a kid, like, don't walk around barefoot because you're going to get tetanus? That was, the puncture wound increases your risk for tetanus, as well as necrotizing fasciitis, which is like my secret, like, deep-seated fear is necrotizing fasciitis. Commonly, it's an anaerobic bacteria introduced to the fascia due to a puncture wound. Puncture wounds, very high risk of infection, because puncture wounds could also result from dog bites, animal bites, human bites. Most of the time, that is associated with bacteria being kind of injected right into that area. We just skipped one. Penetrating chest or abdominal injuries, right? Most of the time, you need to make sure that this is being stabilized, because it could wiggle around and cause more damage. Immobilize the patient as best you can. So, like, for example, let's talk about this patient, right? What are some of the considerations you would have for this gentleman? Okay, so yeah. Well, even if you look out the back, you can see he's got probably like 2 feet out the back. How are you going to get him on the stretcher? Okay, you might lay him on the side. Okay. Okay, you might have to, get creative, right? Who would you call to reduce the size of this rebar? Bring your wire cutters, please. What happens if they start to cut it and the vibrations cause the patient pain? Cease and desist. Good. What organs would you be concerned about? Liver, definitely liver. What else? What? Lungs. Gallbladder. Well, again, where in the respiratory cycle was he when he got impaled? Are you concerned about his spine? How about his... Yeah, like... Gallbladder, yep. Probably good form to put him in a C-spine. Precautions. Probably good practice. Yep, peripheral nerves, absolutely. What other organs? There's another organ. Kidney, beautiful. All right, cool. Avulsions. Avulsions are always fun. So avulsions can be a flap of skin, or it can be like a full-blown degloving. Degloving injuries very rarely have great outcomes, because you got to put all that back together again. So there's very frequently nerve damage and vascular issues. But you can have a patient, like, for example, like if you have somebody who, like that guy with the injury where he like opened up his skull, that in the last lecture, that would be considered an avulsion fracture, even though it's like bone is involved. It's still considered an avulsion. Amputations. Always try to find and keep the other portion of the missing body part. Put it on ice if possible. What was it, like 2 years ago or so? They had that FDNY crew who stopped at a bar to get ice to put the guy's arm on. You don't remember that? He was a known EDP. He was on the subway platform and he tried to jump in front of the subway, but he only like threw his arm out and completely like amputated his arm. Stable when they got there, and there was a bar right by where they picked him up. So when the crew members went in, were like, "Hey, can I get some ice?" And they gave him a thing of ice, and they were all over the news for like 2 days because they're like, they saved his arm because they went to the bar to get ice. So I was like, of course they did. Anyone else goes to go try to do that, you probably got like an NOI, you got written up. Yeah. What did you do? Why are you stopping at a bar? I had to get ice. But do make sure that if you have this body part that you wrap it in sterile gauze and then put it in a plastic bag. You'll put it directly on the ice. Bleeding is a possibility. Oh, hold on. This is another thing. So people are like, oh my God, it's an amputation. It should bleed a lot. If it's a clean amputation, your body has a really cool safety mechanism where it actually all the arteries will clamp down and what's the word I'm looking for? Will like automatically tamponade themselves. So if it's a very clean amputation, there might not be a lot of bleeding. If it's a rugged, like ragged looking, like someone's arm got ripped off, it's going to bleed a lot more because now the muscles of the arteries are not able to clamp down because they've been shredded. So just kind of one of those cool human tricks that we have to keep us alive. Mm-hmm. Mm-hmm. So you could take like a bulky dressing and you can apply pressure by like wrapping it straight across to the other arm. There's a number of really interesting I guess bandaging techniques that you can kind of use, especially for like those central regions, like in a groin, where you're really like wrapping around the hip and like pulling down there, because you're right, it's hard to apply a tourniquet to some of these other locations. You're not cauterizing anything in the field. Definitely get a write-up for that one. Bites. Bites are a combination injury, right? So you have punctures, you have lacerations, you have crush injury, a number of different issues that can be included. Very high risk of infection with any sort of bite. If it's a dog or an animal that is unknown to the person, that requires a police report, because they actually do go and make sure that the animal is either found or because then you have to get rabies shots and all sorts of other stuff. A lot of other concerns, osteomyelitis, depending on how deep the bite is. Tetanus is always a concern. Crush injuries. So we talked about blast injuries already, how there's a number of different stages of a blast injury, so we're not going to really go into that more in depth because I think we've beaten that to death. We will talk about crush injuries, though. So when you start to compress a tissue, it starts to reduce the amount of blood flow to the area. This is probably most clearly seen in bed sores, right? So the length of time and the amount of pressure is going to indicate or determine how badly that tissue becomes devascularized. Now, it also really depends on what part of the body gets injured. You crush a head, it's going to be a lot more significant than crushing a hand, okay? Come on, go. So crush injuries can result from a number of different things, right? So it could be a motor vehicle accident. It could be a guy versus a cow. It could be something like swelling under a cast, right? So if you have a patient who has a broken arm, they go to the doctor puts a cast on, but they wrap it too tight. There's going to be a level of swelling and inflammation underneath, and that can cause a crush injury, even though it's not necessarily the most traditional way that you imagine it. Industrial incidents are really significant, And things that you're probably going to see are going to be unresponsive people lying on a hard surface for an extended period of time, right? Grandma fell out of bed 12 hours ago and someone finally went and checked on her. She could have a crush injury. I think I told you guys the story. I had a lady who had fallen down a half flight of stairs. She spent a few hours laying on her one arm. The weight of her body was significant enough to give her a crush injury to the arm. Okay, so it's not necessarily going to be something as dramatic as like a big old boulder falling onto someone Wile E. Coyote style. It can be something, a little less dramatic looking. So the problem with a crush injury is that when the muscle groups start to get compressed, they start to expand. But when they're surrounded by very thick and very inflexible fascia, that swelling doesn't able to go anywhere. So it creates a significant problem. So you see this guy right here, the color of his leg, that's the potential sign of compartment syndrome. This is really bad though, because usually compartment syndrome is kind of like shiny, okay? Because it's so much pressure in the leg. So if you look right here, they actually did a fasciotomy. Let me get my pen, doodle. If you look right here, they did what's called a fasciotomy, and they sliced open his leg and sliced open the fascia, right? So you have the muscle tissue, and then you have a surrounding fascia, right? That keeps all those muscle tissues, in one spot so that they don't hang out with other people. So once you have swelling in here, the fascia don't expand at all. So what they have to do to release the pressure is actually open it up and let the pressure out, and they leave it open for a few days until the swelling starts to go down, which is pretty wild. A lot of times you'll see this in patients who have circumferential burns. If there's significant bleeding into the compartment, which is most likely what this gentleman had due to the color of his leg. Electrical injuries, because electrical injuries actually injure the muscle themselves, which is what causes the swelling. Vascular occlusions, right? So you'll see this in patients who have DVTs, potentially, or any other peripheral arterial blockages. High pressure injection injuries, I feel like, we went too far. I feel like those are relatively rare, very industrial. Any sort of immobility, and if you screw up your D50, right? So D50 extravasation can also cause compartment syndrome. This is why you always make sure that you have a good vein before you push D50. The 5 P's of compartment syndrome is pain that is kind of out of the realm of what you would expect. Decreased pulse, very white extremity, lack of sensation, right? Paresthesia, and paralysis, where they can't move their foot. If they have, just like with the brain, right? If there has been tissue damage for more than 6 hours, it can potentially be extremely irreversible. As the muscles start to die because of the lack of blood flow, it can cause significant muscle swelling. The problem with once the muscles start to die is they start to release potassium, right? So remember we talked about before where you have sodium outside the cells and you have potassium inside the cells. Once those cells start to die or start to become necrotic, they start to break down and the potassium starts to come out. So the problem with compartment syndrome, especially in the presence of a crush injury, is that if it's been, a few hours, those cells are already damaged and they're already leaking potassium. So if you remove the pressure and restore the blood flow to the extremity, you're now washing all of this potassium into the bloodstream. It's called smiling death because the patients will they start to kind of go like this from all the potassium and they die. They have a significant cardiac abnormal or dysrhythmias and they die. So this is why a lot of the times when you have man unders in the city, This is why it goes to the rescue medics, because they can treat the hyperkalemia before the pressure is removed. So if you have someone whose like arm is pinned under a subway, what they're going to do is they're going to start the line, they'll start some bicarb, they'll start some calcium, like they'll make sure that the patient is prepared for that influx of potassium. They're kind of creating a buffering system so that they don't die. These are patients who require very careful cardiac monitoring, okay? Oh, here we go. We just talked about this. Looking at it real quick. So here's your whatchamacallit. You also are going to give this patient a lot of fluid, okay? Because because you're not only releasing potassium, you're also releasing acid, right? So think about your body if you're not getting blood to the foot. So for example, like the foot is clearly a part that's being affected by this crush injury. So all of the tissue from the injury beyond is going to be hyperkalemic. You're going to have creatinine, which is more muscle breakdown proteins, and you're going to have acidosis because it's now dealing in an anaerobic state because there's no blood flow. So you're going to just completely flood this patient's body with acid and potassium and large protein molecules. So it's really dangerous for the kidneys, which is why we give so much fluid. Let me see if there's anything else. Respiratory issues like ARDS is also another problem. That is because now your lungs are being affected by the same things that's affecting your kidneys. And again, depending on where the crush injury is, you could also end up with significant levels of sepsis. So, soft tissue injuries, right? When we manage them, primarily this is a BLS skill, right? First things first, control the bleeding. If it's bleeding, stop. Do not delay. If there is a reason that you believe that a patient should have a tourniquet, put it on, okay? But they should also be bleeding significantly, okay, right? It's not one of those things where they have like a capillary bleed on their pinky and you're like, let's put a tourniquet on. Like use logic, use your brain, because I know you guys have it. Use the tourniquet appropriately. If there is some level of like significant bleeding, you can go right to the tourniquet. Immobilization is fantastic also, right? Splinting is really good for making sure that the patient doesn't move and dislodge a clot that may be forming and then create more bleeding. And a lot of things that you want to get, a lot of the history that you're going to want to get is what happened, right? Where were you? What time did this happen? What caused the injury? How much blood loss? Are you in pain? Are there any things that are going to complicate this wound, like anticoagulants? You can also get the patient's tetanus status. A lot of people don't know what their tetanus status is. So, they're going to most likely be getting a tetanus booster when they get to the hospital. Things that you want to do, you want to describe the wound, right? Because you're going to go to the hospital and you're going to have it all bandaged up all nicely. And they're going to go, okay, well, what happened? Okay, well, this, and this. All right, well, how big is it? How deep is it? Is it clean? Did you clean it out, right? What's going on? Is there a deformity underneath? The more information you can give to the hospital, the better, because otherwise they're just going to unwrap it. I was doing my medic rotation, and this guy, he fell through a glass table, and he had sliced his arm open, like, right around here. And I'm like, okay. And the medics had put a beautiful pressure bandage on. Like, perfect. The guy wasn't bleeding or anything. No tourniquet, nothing. And they're like, well, what happened? So they tell him what happened. Oh, I fell through a glass table, this, that, the other. Like, okay, cool. And they cut the pressure bandage off and then brought the guy to x-ray. And then x-ray brought the guy back, dripping blood the entire way back to his little station because they're like, we can't x-ray this. It's bleeding. So I don't understand, like a lot of hospitals will just be like, we're just going to take the bandage off. We're just going to take the splint off or whatever. So just keep it in mind that sometimes you could also ask the patient, hey, can I take a picture of this so we can show the hospital so they don't have to unbandage you? Also can work. Or you have the patient take a picture of it with their own phone. There we go. No HIPAA problems there. Make sure that you do your PMS, right? BLS skill right there. Pulse motor sensory before and after bandaging. Is there any damage around to other structures, including skin, bone, joint, etc.? Okay. PMS also here for your perfusion status. Obviously, hemorrhage control, the first thing we're going to do is going to be direct pressure. This will control most bleeding within about 4 to 6 minutes, sometimes faster. Don't remove the dressing, okay? If you happen to bleed through, you put more bandage up on top, okay? Tourniquet, you should be about 2 inches away from the wound. You should not be over a joint. If 2 inches above the wound happens to be a joint, then you put it above the joint. If at first you do not succeed, put on another tourniquet, okay? And make sure that you mark the time of the application. Beyond marking the time of the application, you should also make sure that the tourniquet is in clear view. I had a patient, this was a partner, was telling me that they had a patient once they put a tourniquet on. The guy was like stabbed or something in the leg, and he was like, this hurts, this hurts, this hurts. And they're like, no, it's okay. So what do you do for a trauma patient? How do you treat for shock, BLS-wise? Keep them warm, elevate the legs. So they covered him with a blanket. And while he was covered with the blanket, he loosened the tourniquet and bled out on the stretcher. So this is why you want to make sure that you, 1, reassess, 2, keep your tourniquet revealed. Because also you don't want to go to the hospital and be like, yeah, he's got a tourniquet on. The triage is like, yeah, whatever. And they kind of blow you off. And then the guy's sitting there with the tourniquet for an extended period of time and then loses a whole limb. So make sure that you document everything appropriately. Write it on their forehead. If you can't get the ink to work on them, write it on a piece of tape and slap the tape on their forehead, okay? You can also use their own blood, but that's a little crude. You don't maybe want to do that. What else we got? So we were talking about this, Rob. So we were talking about how if you have somebody who has an injury where you can't put a tourniquet on, so beyond like a completely shredded shoulder. So like this, for example, maybe if he has a shredded shoulder, you would use a junctional hemorrhage, a junctional tourniquet, okay? So you could apply to up around his neck or up across to his shoulder to help apply pressure, right? So you're using traction against another body part in order to reduce the bleeding. Other things that you can do, this is a junctional tourniquet that they use high in the femur. Another thing that we also have for abdominal injuries is the, what's it called? Someone help me here. We pack the wound with it. Quick clot. Thank you, Danny, for the win. So if you have injuries in any of these locations, the groin, the shoulder, or like the armpit or the base of the neck, they have commercial devices, but you can also create them yourself, okay? These looks like he's got some hardcore cling going on there. There it is, quick clot. They have this now in protocol. I don't know if it's a specific protocol for trauma because they don't want people using this for everything. They have significantly improved the formula for quick clot because it used to cause like a burning sensation because of what it was made with. It's no longer made with that. It's actually made with clay. And the clay actually causes the blood to start clotting. So you are allowed to pack the wound with quick clot, but you first must identify the location that is bleeding. This is traditionally used in the abdominal region. So you go and you maybe see, okay, that's where it's bleeding, and then you will stuff the actual wound with this, because when you kind of expand it, it's just like a long, whatchamacallit. The little blue line on it is radiographic, so if they x-ray the patient, they can find the bandage. TXA, we talked about this. It's good to know about. No knowledge of that they're ever going to bring it here to America, or at least New York. This is used to prevent bleeding because it causes plasminogen to become plasmin, which prevents clot breakdown. So if you have somebody who's going into something like DIC or something like that, what they'll do is they'll use the TXA to help improve clotting. This is usually used in very long transports, in the hospital, obviously. We don't really use it here, as far as I know, in the United States. All right. Come on. My computer fell apart for a minute there. All right. Questions, thoughts, concerns? Someone get Matt Levin's coffee. All right, cool. Last one. Go away. Burns. Because if you weren't having a cheery enough morning, let's talk about burns. Burns are associated with very high mortality rates. They're a very complex medical emergency, and they lead to a lot of complications because as humans, we're very watery. We're kind of just very emotional cucumbers, if you really think of it. The problem right now with especially homes is that it's not just like wood construction anymore. It's a lot of plastics and a lot of commercially made products that burn very, very hot. So not only are you at an increased risk for cyanide inhalation, which is going to kill you, you are also at increased risk for airway burns and just significant disfiguring, like thermal burns. The type of tissue destruction is dependent upon a lot of different things. Obviously, as with most other things, pediatrics and geriatrics are going to be the most susceptible to burns and burn injuries and the morbidity mortality rates associated with them. So, thermal burns, okay? Thermal burns is anything a hot substance. If it is 156 degrees or more, you will be burnt after about 1 second. If you think about boiling water is at 212 degrees, okay? If you are cooking pork, right? You ever check your pork with a meat thermometer? Pork is the closest tissue to human tissue. It's considered cooked when it's 165 degrees in the center. So just kind of use that for some context. Chemical burns will disrupt the structure of the skin by breaking down the proteins, right? So your cells are going to be destroyed. If there's involvement of the eyes, esophagus, or airway, there's a super high morbidity mortality rate. Electrical burns, beyond just the fact that an electrical shock can stop your heart, it causes a lot of other injuries through direct contact. You can also have intense heat from an arc. And then you have radiation, which causes all sorts of other issues, right? So you'll have what appears like, patients who go to get radiation treatment, they'll have like an area of red irritation on their skin from the actual therapy. Or you can go directly to Chernobyl kind of radiation, where you're just kind of dissolved. Come on. Thank you. So when you have a patient who has a burn, there's 3 distinct zones, okay? So the first zone is in the center. It's called the zone of coagulation. This is the most damaged tissue, okay? This is the part that has been directly burned. And think of this sort of like an MI. Remember when we talked about how when you have an MI, you have the part that's being fed directly by that artery, and then you have all the area around it that starts to become ischemic? Kind of the same vibe, okay? So you have this middle area, which is just dead. And then you have this area around it, which is called the zone of stasis, which may or may not be affected as significantly, right? So this is the area of a potential healing. And then you have the area around it, which is the zone of hyperanemia, which will have an increased blood flow due to this a normal inflammatory response, okay? But now if you think about it, as you have this zone of hyperemia around it, it's increasing the blood flow, which means that you're losing plasma, okay? So this is one of the complications of burns. As you're increasing blood flow to this damaged area, you start to lose plasma, and you're, among other mechanisms, and you start to become hypotensive. So depending on what level of heat and or duration that you have, will determine what degree burn you have, right? So they keep changing what it's called, but back in the day, we would call it first degree, second degree, or third degree. I think we call it now partial or superficial, partial thickness, and full thickness burns. Your first degree burn is your traditional sunburn, right? You're kind of red, you're kind of uncomfortable, but you're not dying. Your second degree burn is when you start to see blisters. And yes, I know that there are some people who've been sunburned who've had blisters. It's still considered a second degree burn, okay? Because now you have increased capillary permeability that's creating those little wet blisters. And then you can move all the way to a third degree burn, which is, as we said, that full thickness burn. It goes all the way down through the epidermis, the dermis, into the subcutaneous fat. Then that's also one of the delineating factors between first degree and second degree, where your first degree burn really just involves the epidermis. The second degree involves the epidermis and the dermis. There's also a fourth degree burn, which is considered, which is when you have charred bone, okay? Most of the time, because burns are also associated with heat, you have very hot skin, which means that the water is being evaporated in that area. You also are losing water because the sodium pumps are injured, okay? So you have swelling, you have evaporative losses, you have inflammation that's releasing plasma into an injured area. If you ever had a burn, they kind of just seep, right? They can just like have that like weepy kind of response. So if you have a patient who does have a burn, they tend to have, especially a significant burn, they will have a systemic response. So you will have hyperventilation because you're now shunting blood away from the GI tract. You will potentially have vomiting, especially if the patient has eaten recently, because they are no longer able to digest because the blood's going elsewhere. The area that is burned will have a decreased range of motion. Your body goes through that fight or flight response, right? So it's going to have increased epinephrine, norepinephrine. You're going to have because of the increased epinephrine, you're going to have an elevated heart rate. Because of the increased norepinephrine, you're going to have peripheral constriction. And then aldosterone, right? Because that starts the ADH cascade. So that's kind of helping keep your blood pressure up. It's also trying to keep as much fluid in your body as possible. This is why burn patients require so much, part of the reason burn patients require so much fluid. Your metabolism will go up because now your body's trying to repair itself. You obviously are going to be more susceptible to infection because you have this big open to the environment injury. And there's a lot of emotional issues kind of related to bad burns, obviously. So here we go. We've got your superficial sunburn, your partial thickness, where you totally forgot that you put something, you turned the oven on and grabbed it real quick and had a blister, and then your full thickness, which is going all the way through. Usually the third degree burns is when you they stop feeling pain to the same extent, because those nerves are significantly injured. My recommendation to you is, when you get to the state test, you draw yourself a stick figure and you put your rule of nines down. Because I don't know about you, but that's one of the things that I almost always forget. And there's almost always at least 2 to 3 questions on the state test about the rule of nines. And you'll also notice, right, we have differences in the rule of nines between pediatrics and adults. That big old pumpkin head, right, it starts to account for more in an infant. It's very accurate for adults and children when it's over 10%, not so much for babies, because again, their body surface area shape is distributed a little bit differently. And sometimes it's hard to kind of, I guess, estimate how much area is burned if it's not like one specific area, like a splash burn, for example. So then we use the rule of palms, which is the size of your palm is about 1% of your own personal body surface area. So that doesn't mean that, like, if I'm going up to an NBA player going, yes, this is 1% of your body surface area. It's not my palm, it's their palm. Okay, always, it's sort of like when you're measuring for an OPA, it's the thickness of the patient's, or an NPA, the measure of the patient's pinky, not your pinky. Same vibe. There's another chart that is used to estimate the severity and extent of burns, which is the London Browder chart, which is fantastic because you get 2.5% for a butt cheek. That's fantastic. That's amusing to me. It gives you a little bit more of a accurate estimation because of the developmental changes that kind of take place. It calculates it a little bit more accurately, but for the state test, definitely use the rule of nines. So the American Burn Association categorizes burns based on these factors: the extent, the depth, the location, the age of the patient, etiologic agents involved, like what caused the burn, the presence of an inhalation injury, and any other coexisting injuries or pre-existing illnesses. So, if you look at this gentleman right here, I can't tell you much about anything other than the fact that it is in fact it does involve an inhalation injury. Okay, right? That's significant burn because it's going to be a complicated case. Burn center referral. So you do need to go to a burn center or call to go to a burn center in the city, and you're going to be going into Manhattan if you're working in Queens, Brooklyn, Staten Island. Like, I think almost the only burn center is in Manhattan off the top of my head. It's Cornell, I believe. So there's different criteria. And again, you want to check in your GOPs for what the New York City criteria is because it may be more sensitive than this one. But this is going to depend on what your best transport decision is going to be. So anything more than 20% in adults or 10% in children, anything more than 5% of a full thickness burn in any of these categories should go to a what should we call it? Oh Lord, chat just threw off the whole thing. You should be going to a burn center. If you have a patient who has some sort of comorbidity, right? Diabetes, sickle cell, etc., you should be going to a hospital that can manage burns, but does not necessarily mean that they need to be going to a burn center, okay? So just some criteria that you should kind of take into consideration. So burn shock, right? This is the time to shine as a paramedic. So as your injured tissues start to call for more blood, the fluid that's in your blood starts to evaporate, okay? You start to lose sodium. Just like in a crush injury, those injured cells start to release potassium, so you have increased potassium problems. And the blood starts to become concentrated as you reduce the amount of plasma that's around. So that means that you have very sticky blood. You have an increased chance of clotting. You have a lot of proteins, right, from the muscles that are damaged, and a lot of proteins from the blood that's being damaged as well, that's floating around. So as your vascular permeability goes up, you have increased edema and a decreased intravascular volume, okay? And as this goes through, your blood starts to get more sticky. It's harder for your blood. Your blood volume goes down, and it starts to get harder for your heart to pump. And this is one of the reasons that we give patients so much fluid. So there's a number of stages of burn shock. The emergent stage is when you have a decreased level of blood flow to the burn, okay? This is through the cauterization process. So then you have increased vasodilation that is trying to increase blood flow to the burn. As that starts to happen, you have the second stage, which is the fluid shift. The wound and the burn starts to become edematous. The plasma is being pulled there to create the edema, which means you start to have hypovolemia and more fluid loss. As that extravasation starts to diminish, your body starts to kind of reach this kind of weird equilibrium between the two, but you're still at a decreased cardiac output, so the rest of your body is not getting the amount of oxygen that it needs. And then you have hypermetabolic of state burn shock, which is if you do actually do the volume replacement that's necessary, everything can kind of start to return to normal. So, just like any other injury, you don't want to get distracted by a dramatic looking burn, okay? Just because it looks really bad or smells really bad doesn't mean that there's something else, not something else going on underneath, right? Is the patient in respiratory arrest? Are there broken bones that need to be managed, right? Because certain temperatures, it could cause bones to snap, especially in like the elderly. You could have an inhalation injury, right? Patients who have that soot in the nose and mouth is probably singed facial hair is going to be some of the easiest things to see. Patients who are coughing with a hoarse voice, any sort of circumferential burns to the neck, right? Circumferential burns are one of the most dangerous things that you can be dealing with, not only in the extremities, but particularly in the neck, because once those, we talked about that edema flow, right? Once those tissues start to call for the edema, it's going to close the airway down. So you need to make sure that if you have a patient who you have like a circumferential neck or thorax burn, that you get that airway under control rapidly. Some indicators of a decreasing airway, okay, burned tongue, mouth swelling with no stridor in general, visible edema, hoarseness of the throat or the voice, any sort of burns around the nose or mouth, and soot as well, soot and singed hairs. So things that you want to make sure that you assess during your primary survey and reassess very carefully as you transport. Breathing, right? Because we talked about the airway already. So now breathing is obviously very essential. Are they breathing adequately? Are they breathing with difficulty? Are they a smoke inhalation patient? Do they have airway burns that might be affecting their ability to breathe? And circulation, right? So are you going to be able to get, depending on their burn, you want to get where the burn location is. You're going to try to get an SpO2. If you have a RAD 57 on the truck, you should get that too, because they might have carbon monoxide poisoning due to these being in a fire. Capillary refill, pulses, blood pressure is also good to get as well. Their skin temperature, color, and condition may or may not be accurate depending on how much body surface area is involved, right? Because if you have a patient with extensive burns, they're not going to be, easy to assess. A lot of the times where you take the patient is going to be determined by how much injury is noted, right? So we talked about the chart already, and go definitely check the GOPs to kind of understand where the lines are drawn between going to a trauma center or going to a burn center. If you have a patient who has undergone any level of trauma whatsoever, they need to still go to a trauma center. That's the number one priority. So most of the time, the most important part of the management of burns is the number one thing you must do is actually, stop the burn. Obviously, the airway is important. Your ABCs are always important. And this is one of those things where you may need to be managing the patient's pain relatively aggressively. Again, if you look at your protocols, they have a pain management for burns protocol. It's pretty liberal, I guess. I guess that's the right word. Also, just like any other patient, you want to make sure that you're going to maintain their body heat. You definitely want to try to clean their wounds, but again, if you have somebody who has extensive body surface area injury or burns, you're not going to want to irrigate those injuries significantly because you're going to lose a lot of body heat because of the cold water. Psychological, emotional support, because they're going to have obviously a tough time. This is a test question. The first step of managing any burn is to stop the burn process. Cool tap water is good for superficial burns, right? I think that's like a common sense thing. You burn yourself at home and what's the first thing you do? You go and run it under the tap. Removing any clothes that need to be removed in order to prevent heat trapping because you don't want to make them hotter. Stop, drop, and roll. It's always a good start. If you have large body surface area that is burned, it's a good thing to use the burn sheet. Burn sheets, I don't know if anyone's ever opened up a burn sheet. They're a little challenging to manage. There's a lot of that. If you have a patient who has less than 9% body surface area, moist, sterile dressings are frequently recommended to kind of also help manage the pain. Oh, goodness. If you have a patient who has burns to the extremities, like the fingers or the toes, you want to make sure that you put bandages in between each individual finger, toe, so that they don't start to fuse together. Patients with airway burns, it's very nice to give them humidified oxygen if you have the ability. If you have any suspicion that you might have an airway compromise in the future, you should be aggressive in your management. If you have a patient who has an airway burn or has a circumferential thoracic burn, it might be hard to ventilate that patient. So those are things you need to keep in mind. Patients who have dealt with significant burns have lifelong issues in so much as all of those sweat glands are now gone, right? So they aren't able to maintain their body heat or their body temperature effectively. The amount of fluid resuscitation is frequently determined by how severe the patient's injuries are, what their vital signs are, how long it's going to take it to get to the receiving facility, and the total body surface area involved. If you have a patient who you're trying to give IV therapy to and there are all sorts of burns, you don't want to cause them more pain. So you're trying to find a place that is not burned in order to try to start that IV. This here is your Parkland formula. This is very important to know. It's used to help calculate how much fluid the patient's going to require. So what you usually do is that it's 4 milliliters times the total body surface area that is burnt times the body's weight in kilograms. So if you have, for example, let me get my little pen. Come on. So if you have a patient who is 176 pounds, how many kilograms am I? 80. Good. Okay, and this patient has sustained a 20% body surface area burn times 4. Or here, I'll make it a little simpler in the math realm for some people. So let's start off. No, that's still. So, right, so 0 times 0, 0 times 0. 2 times 0 is 0, 2 times 8 is 16. So then you have 1600 times 4. So that's 4 times 0, 0, 4 times 0 is 0, 4 times 6 is 24. 4 times 1 is 4, plus 2 is 6. So this patient is going to need 6,400 milliliters of fluid in the first 24 hours. So that means that they're going to get 3,200 milliliters here in the first 8 hours, and they're going to get 3,200 milliliters in the next 16. Okay, that's in 24 hours. Okay, that is 6.4 liters of fluid. That's significant. Okay, that's a lot of fluid that this patient's going to need. So if you can start this fluid process en route, they're going to be better off. So if you get 2 large bore IVs and you hang a liter bag each, you're 2 liters of the way to your first 3,200 or 3.2, right? So then you're only helping the patient. So rule of 10, calculate your total body surface area to the nearest 10%. So for example, if you he's got a 16% burn, bump that up to 20. Multiply that by 10 for the initial fluid rate. So if the patient's within 40 to 80 kilograms, so multiply, that's 200. And then add 100 milliliters for every 10 kilograms of patient weight over 80 kilograms. Or you can just do the regular old math. Go ahead. It's going to depend, I think, on how hypotensive your patient is. If they're really hypotensive, you could definitely do a pressure bag. It's not going to, in the long term, probably not going to help them or hurt them. But it also depends on how far away from the hospital you are. You know, if you have time to let it flow normally, you're okay. So, and if you also look at your protocols, I believe you get, for a burn patient, you get up to 3 liters of fluid, standing orders. So if you are, 15 minutes or 20 minutes from the hospital and you've already given them 3 liters, now there's like a gap between where you are and where the hospital is going to be able to. So, but again, you're going to look at the whole picture of the patient to kind of determine one way or the other if you're going to need the pressure bag. But definitely a good idea. Where did my share screen go? All right. So some special considerations when it comes to burns. 1 is the face. Facial burns will swell up very, very quickly, okay? Which means that you're also going to have an issue when it comes to airway, especially the circumferential around the neck. Like if you look at this guy, you think you're going to be able to tube this guy okay? Like that's going to be a challenge. If you elevate the head to about 30 degrees, right? So you're sitting semi-Fowlers, you will reduce some of the edema that's going towards that region. Extremities, okay? We talked about the fasciotomy when it comes to a crush injury. They will do the same thing with patients who have bad bird injuries to reduce the damage to muscles underneath. Except when it's done on a burn patient, it's called an eschorotomy or escharotomy, depending on how German you're feeling on that pronunciation. It's important that anything that could be constrictive to this patient, rings, watches, other jewelry, is removed, okay? Because it's only going to cause more complications. And you should also try to elevate their limbs if they are involved and check the, whatchamacallit. So when I said escharotomy, right, here we are. This patient has significant burns and they're circumferential. The circumferential burns will create a tourniquet-like effect, right? Because now think about when you barbecue like a steak, right? And it started you put the heat on it, it starts to kind of shrink, and it maybe gets a little crusty, a little, crispy outer layer. That's exactly what's happening to the human body during a burn. So if you're unable to get good chest excursion because your skin is tightening up from this burn, you're going to become hypoxic. So what they do is they actually will go and perform what's called, as I said, the escharotomy, and they'll cut the skin to allow for the chest to expand, or they'll cut the skin on the extremities in order to allow the swelling from the damaged tissues underneath to escape, so that you're not creating that compartment syndrome that you see in a crush injury, because you can have a crush injury just from tightening skin. It's the same process. About 77% of deaths from residential fires are resultant from pulmonary complications, right? So this is why it's important that you have that you transport patients who may have been involved in a residential or involved in a fire. Inhalation injuries increase morbidity and mortality from burns, right? Obviously, it's just adding another inside or internal aspect that you can't see and will have potentially a difficult time managing because of that. A lot of the other concerns are carbon monoxide and cyanide poisoning that can contribute to inhalation injury death, okay? If you look here, there's an interesting little chart as to the percentage of carbon monoxide in the blood. So if you are less than 10, you are either healthy or a smoker, because smokers actually live around 5 to 8, depending on how much they smoke. As you start to get towards the 20 to 30 range, right, you start to feel a little drowsy, might be a headache. As you get closer to 50, you have increased concerns, right? So you'll have blurred vision and confusion, impaired judgment, sort of like they're drunk. They could have vomiting, memory loss, and then death, just slight side effect. When you have inhalation injuries, there's two different areas that we need to concern about. If it's above the glottis, it's usually because the environmental air is superheated, and that will actually cause the vocal cords to kind of clamp down to protect the lungs. So you'll have a lot of edema in the mouth and the upper airway. So this is that point in time where you really need to make sure that you get a tube in there. If the injury has gone down below the glottis, it's usually due to like a toxic material, heat or steam, because steam is a lot more dangerous than you think it is. Explosions, which actually force the vocal cords open and force the hot air into the lungs, or aspiration of scalding liquids, which just sounds horrible. A lot of the signs and symptoms that you'll see with an inhalation injury are kind of across the board, toxic or otherwise, right? So you'll have wheezing, crackles and rhonchi as the lungs try to protect themselves. Productive cough might bring up clear sputum, might be a sooty sputum if it was in a residential fire or some other type. You might have a patient who has signs of hypoxia as well. Chemical burns can come in a lot of different environments. So there's 3 types, right? So you have your alkalis, which is your strong bases with a high pH, right? So that's a pH of like 10, etc. These are your bleaches, right? Stuff like bleach. Then you have your acids, which are a low pH. There's a lot of hydrogen ions. This is your hydrochloric acid. And then you have chemical organic compounds like phenols, petroleum products, etc. could both burn and be absorbed. Just like we spoke about earlier when we were talking, I believe, of weapons of mass destruction, your alkalis are going to create more damage than acids will, because they start to necrotize the flesh and they're very hard to get off. Okay, they're very slippery. Like, think about bleach. Bleach is your best example of how that is a slippery kind of substance that is hard to get off. So when you're talking about chemical burns, these are some of the questions that you need to ask. What kind of chemical was involved? What was the concentration of the chemical and the volume? Like how much? So if you have like a gallon of acid, that's a very high concentration. That's a bad thing. How was the chemical burn inflicted? Right? Did someone put their hand in bleach? Did someone inject it? Was it a splash injury? A lot of at-home chemical burn problems tend to be splash injuries. But usually it's like, they dropped a container or they were cleaning or something to that effect. What time did the contamination occur? Was any first aid rendered prior to your arrival? And what's the patient's complaint, right? Are they in pain? Are their injury looking significant? Et cetera, et cetera. Important thing is you need to make sure that you're safe, right? Number 1 rule. And then you need to decontaminate the patient. Powder chemicals you should always brush off first. That's commonly a test question. If you have a patient who has like blisters that are containing chemicals, you would need to remove those. And water, right? Water is the number 1 solvent to reduce chemical burns, except for sodium metal. Right? That's explosive. Don't do that. If a patient happens to end up with a chemical burn in their eye, you want to make sure that you are irrigating that eye with copious amounts of water. You also have in your protocols tetracaine or procanamide tetracaine. I forgot the other one because everyone carries tetracaine. Carries tetracaine as a ophthalmologic pain reliever. Okay, so you can provide that if necessary. A couple of different things. They have what's called the Morgan lens, which is this creepy looking contact lens that you put in somebody's eye and it directly irrigates the eye. Or if you're feeling crafty, you can take a liter bag, hook it up to a macro drip, and hook that macro drip up to a nasal cannula to irrigate the eyes in this fashion. you want to make sure that you use the nose effectively to keep the irrigation fluid away from each other, right? Because you don't want to cross-contaminate the other eye. Different chemicals that can cause burns, right? Petroleum, as with prolonged contact, it could be a lot. Might not look significant, but it really can be. If it is ingested or something, it could also really lead to central nervous system depression, organ failure, or death. Always fun. Phenol or carbolic acid is used in a lot of, or as disinfectants, so it can cause like a painless coagulation because it does have anesthetic properties. If extended exposure can lead to a systemic toxicity. Ammonia is a noxious gas, can cause significant airway issues as well as burns to the eyes because it does react very well with water. And remember, humans are just emotional cucumbers, so we are very, very watery. So ammonia in the air can cause significant issues for us. Respiratory issues related to ammonia are 100% dependent upon what the concentration of the ammonia is and how long the exposure is. Same thing with chlorine, they're very similar. So you might end up seeing airway edema, wheezing, etc. Sodium, potassium, right? We said don't flush these out with water because they're highly reactive and explode in water. I think everyone's done this in their high school chemistry where they explode some sodium in water. These need to be covered with oil. Again, this was not something that you're probably going to see on the regular unless you're working in a super industrial area or a high school chemistry lab. Hydrofluoric acid is extremely dangerous, okay? It's a very, very potent acid. The chemical it's hydrogen and fluoride. It is used mostly in industries. They use it to clean fabric and etch glass. But a lot of the times when they're etching glass, it's hydrofluoric acid under pressure, and it ends up being injected under high pressure into usually a finger or a hand. So now you have not only a deep like an under the skin acid burn, but you also have cavitation from the high pressure injection. And the problem with hydrofluoric acid is that it leaches calcium. So it will start to leach calcium out of the bones and the muscles, which can cause all sorts of cardiac dysrhythmias. It's super, super dangerous. The treatment for hydrofluoric acid exposure is is calcium gluconate applied to the wound. We don't carry calcium gluconate. We can use calcium chloride, which is what we carry. The calcium gluconate is a little quote unquote nicer because especially in the IV setting, calcium chloride, I actually asked a doctor what the difference was. Calcium chloride is a little more painful and irritates the veins, where calcium gluconate is not as irritating. Electrical burns. So when you have a patient who you suspect has an electrical burn, you want to look for your entrance and your exit wound, right? Because it is a possibility that electrical current has crossed over the heart and that there are cardiac arrhythmias going on as well. Sort of like when we talk about when we're defibrillating a patient, a continued contact with electricity reduces the body's resistance to the electric, right? So if you defibrillate somebody the first time, the electric's not going to travel across their chest as easily as the sixth time you're defibrillating them. Most of the tissue damage, the significant tissue damage, is right around the contact points of the electrical, where the electric enters. Electric can also create arc injuries, so that's extremely high voltage that then jumps through a person, much like a Marvel plot, and then the temperature is extremely hot. So we talked about how, a burn can occur at 156 degrees Fahrenheit. An electrical arc can be as hot as 3,000. So it's sort of like getting struck by lightning. Flame and flash electrical burns are very commonly what causes eye injuries. They can also very easily ignite clothing, but commonly there's not a lot of electric that passes through the body itself. A lot of the time, the electrical burn, you really need to make sure that you are evaluating a cardiac dysrhythmia. If you're in the city, any call that comes over as an electrocution is automatically an ALS call. Okay. A lot of injuries due to electric can kind of be dependent upon how many amps of current are going through the patient. The skin is commonly the first contact, so you'll end up seeing like an ulcerated and or exploded limb or body part. So when we measure our what's the word? Transcutaneous pacing in milliamps, right? So when you guys are doing your practice, you see that we kind of get up to like 50 to 150, okay? But it's a short little milliamp, right? Because we're just taking over the heart. But like if you're over here and like this over 2000 milliamp, death is probable, okay? So you just kind of use that as your range of whatchamacallit, context. So when you're doing a physical exam for a patient who you suspect has an electrical burn, you should look for your entrance and exit wounds. There is the possibility of multiple paths, so keep that in mind. Electric is also very violent, so it causes significant muscle contractions, which can actually cause bone fractures. Cardiac monitoring is essential. Just like any other burn, make sure that you ensure proper hydration of your patient. Manage the wounds, the entrance and exit wounds, just like you would any other injury, right? You keep them dry and sterile. Now, electrical burn or lightning injuries are super, super wild. People tend to somehow survive lightning strikes. The problem is if you've been struck by lightning once, you are more likely to be struck by lightning again. It could be a direct strike or a side flash, and you are going to be hit with about 200,000 amps of electricity and about 50,000 degrees of temperature. But it's very, very brief, which is, I think, why people don't die as aggressively. Florida, Louisiana, and Mississippi are the most common states for lightning strikes. So if you feel like you don't want to get struck by lightning, maybe we avoid those states. Lightning injury has this really wild kind of burn pattern this is very characteristic of a lightning strike. It doesn't go through the body, but it kind of goes over the body. So I guess Pikachu might actually be the most accurate description, right? He's this kind of like this little electric ball and he has it over his skin rather than through the skin. So full thickness burns are not particularly common in lightning strikes. The bigger problem you're going to have is the patient's confused, may have eardrum rupture, and could also be in cardiac or respiratory arrest. That's a lot of electric, which can potentially just totally restart the heart. Radiation exposure is an issue. It's one of those things that I think it's one of the biggest fears when it comes to like the potential of nuclear warfare now, because we saw what happened in Japan after we dropped the bombs. Ionizing radiation is energy released from atoms that travels in electromagnetic waves that we as humans pretty much have produced through nuclear weapons and reactors. There is radiation exposure that is relatively safe. Radio waves and microwaves are probably two of them because they don't create as much significant issue. It's just a lower concentration. So, things that you will definitely need to know the difference between is your radioactive particles. Your alpha waves or your alpha particles are very large and can travel only a few millimeters. They are very easily stopped by paper or clothing or skin. The problem with alpha radiation is that you can actually get radiation poisoning from it by ingesting it, inhaling it, or absorbing it through the skin. On the other hand, you have beta, which are much smaller than alpha particles. They have more energy behind them, which means that they can penetrate further than alpha particles can. Um, Usually they'll go enter the skin through damaged skin ingestion or inhalation. Your Then you move up to your gamma and X-rays, right? So X-rays we're pretty familiar with. They can obviously go through the body because this is what we use to evaluate bones. Um, Gamma rays are considered the most dangerous form of penetrating radiation. These are the things that require lead shields, like right. So you go in for an X-ray, and the area that they're not imaging, they tend to cover with that lead gown. Um, Gamma rays are 10,000 times more powerful than beta, and they will cause various skin burns, extensive internal damage, right? Because the problem with radiation is it actually alters your DNA. This is what they were finding in Chernobyl and Hiroshima, etc. Is that these radioactive particles will change you as at the molecular DNA level. So here's a little whatchamacallit, a nice little description for you where you have your alpha rays get stopped by aluminum, your beta rays, your alpha rays get stopped by paper, beta rays by aluminum, and your gamma rays, most of them get stopped by lead. Radiation doses, right? So this is one of those things where like you see all the radiologists and the x-ray techs, etc., have the little exposure doodad, whatever, I forgot what it's called, because you don't want to be exposed to a significant amount of radiation on the regular. It's just not good for you. It causes all sorts of biological issues. So 1 Roentgen is equal to 1 REM, which is equal to 1 rad. Just kind of keep that in mind. It's not, not super important to know. Just keep that in the back of your mind. But if you look here, right, so if you get an abdominal CT scan, you're exposed to 1,000 mRem. Okay. This is why a lot of patients, you can't get a certain number of x-rays within a year or a certain number of CTs within a year. They try to limit that because they don't want to give you radiation poisoning. This thing, I forgot what that's called. Just like any other emergency response to a weapon of mass destruction or fire, etc., you want to be upwind, uphill, upstream from wherever the site is. Because you can ingest radiation, you should not be eating or drinking at the site or in the rescue vehicle that you're working in. You should have appropriate protective clothing. You should have dose meters. And the patient should be moved out of the radiation area as quickly as possible. This is somebody else who is going to require a decontamination. However, you are also not necessarily trained to be working at anywhere other than the cool zone. So it's not necessarily your responsibility to be moving patients away from radiation or decontaminating them. Time, distance, shielding, and quantity. This is important for every sort of exposure, not just radiation. The more dense a material that is between you and the radiation, the better. This is why we use lead. Farther away is the better, and for the least amount of time. Here's your decontamination procedures. So 1, get naked. 2, take a shower. 3, put on clean clothes. And then 4, help other people. I don't know why, if you were here at Wash Yourself Off, you couldn't maybe take the dog and the kid into the shower with you and go, all right, everybody, we're going to get clean. But, the CDC, they make the rules. There's different levels, right? So you have clean, which is exposed but not contaminated, dirty, which is exposed and contaminated. You are not qualified. Well, as far as I know, most of y'all are not qualified to work on radiation sites, so you will continue being non-superheroes. That's all I got for y'all. Any questions? Oh, what's going on in the chat? Let's check real quick. Yeah, definitely. Yeah, definitely go play in Lightning. It's a great idea. All right, guys. If there's no questions, no things, we'll resume on Thursday with a review for Module 6. We will do a scenario or two tying in the protocols. So if you have any interesting calls, please send them to me so that I can put it together. And if nothing else, have a safe day.